forward in go in a direction parallel to the iris. And as you can see here, the rexus is already done. But if your main tunnel is done before the rexus, then you can jeopardize opening the posterior capsule if you're still pointing backwards. Classically, this is how you want your wound to look like. This is the entrance at the beginning is a vertical entrance, and then you go lamillar, and then you go dipping, and once you dip inside and you're inside the anterior chamber, you go parallel to the plane of the iris. And eventually, this is how your wound should look like. Again, another video for the main tunnel with like a bad type of a keratome. It's giving us a resistance, so I can fix the globe from here and then make sure that I go in. Only the shoulders pass, the widest part passes, and then I don't need, once the widest part has passed, I don't need to go further forward. Once the widest part of the keratome has passed the inner side of my wound, I don't need to go further. Having had the rexus pre-made before the main tunnel gives me a chance to secure myself and makes me very confident that I will not do any injury to the anterior capsule. Another time, main tunnel, slowly. Your surgical openings are critical, very critical to perform a smooth surgery. Okay, here you can see I have a pannus. Okay, I choose to go a clear corneal incision, Some people would prefer to go through the pannus because if the pannus is vascularized, it promotes healing faster. While for me, I prefer sealing after the surgery. I prefer to go sealing. It's much easier to hydrate and seal the clear cornea than to hydrate and seal fibrosed pannus. Now, after you have done your side ports as part of my surgery, I start doing the viscoelastic. You start introducing the viscoelastic. There's a very beneficial benefit from putting a viscoelastic early is it maintains your AC. So now, to put your viscoelastic, you need to go to the other side of the surgical incision that you've done and then inject while withdrawing backwards. As you can see, let's see this again. You go inside, start injecting as you pass to the other side, and then when you're here, you inject and then withdraw. Inject copiously and withdraw. And you can see the line going backwards. All the fluid now is coming out of the surgical incision, and the AC is fully filled with viscoelastic. If you start injecting viscoelastic from this side and then you move forward, you can entrap fluid here, and that will compromise your anterior chamber once you start doing surgical maneuvers inside. This is another movie. Okay, this is another movie for the introduction of viscoelastic. As you can see, I'm injecting as I'm moving there, and then I start injecting copiously. The injection at the beginning is just to maintain a track for myself so that the AC does not collapse. And as you can see, I'm injecting my viscoelastic from the side board. And I will show you why I'm doing this, because with here, if I'm giving the basic course, I'm always trying to give you the safest mode of doing surgery and the steps that gives you reproducible results. Now I'm going to start discussing something critical before I start discussing the rexes, which is handling your instrument inside the eye. If you have an instrument inside the eye and you want to move this instrument from point A to point B, so let's say I have a cystotome, or for example, I have a cystotome, and I want to move my cystotome from point A to point B. If I move my instrument to point B and I move the whole instrument to this side, this will result in the first rotation of the globe, second movement of the globe towards this direction, and then also corrugations at the level of the cornea that will hinder your visualization. So what is the best way to do this? The best way is to move the back of your instrument in the opposite direction. You move the back of your instrument to the opposite direction, that will give you a movement of the tip towards point B without moving the hinge or the entrance place. And that will give you stable globe, well visualization, and without corrugations in the cornea, so you can see the inside of the eye clearly. You don't have any problems with eye movement. As you can see in this drawing, it tells you what happens. If you pull your instrument up, you get corrugations in the cornea. If you pull the chopper up, it will cause corrugations in the cornea. If you push the whole instrument from point A to B, you're pushing, you get corrugations on this side, and the eye moves. If you move the way we said, you move the tip to A to B, but the back of the instrument moves on the opposite direction, that will give you a smooth movement and steady globe with visualization without hindering by corrugations or striae. Now we go to the rexus part. First, you have to realize the difference between creating a tear by shearing or by ripping. Shearing gives you, if you use the ripping, you get more resistance from tissue parts or tissue bonds. If you use the shearing, you get the lesser resistance. And in this part, I will open my camera, and then I will try to show you how this could look like. Okay, so okay, block fine. Sorry. Okay. So now this piece of paper in front of me, if I have a tear, a small tear in it, and I want to extend this tear from this point to a small point under it, okay? If I use tearing, which is I'm going to hold from here and then pull them apart. I'm going to pull them apart, like in the drawing in front of you, the lower part, the lower drawing here, lower half of the screen. If I start pulling to the sides, I'm going to start slowly, gently pulling to the sides, and then suddenly I get a tear. See how the tear extends a very long distance. Now, I don't want that. What happened is I had resistance from several points. Now look at the drawing in front of you. I have resistance from point A and point B and point C. The point A gives me the most resistance, but B is aiding in the resistance, C is aiding, and D also is aiding. So once I reach enough power to break A, I break B and C and D quickly, and everything breaks away. So I get a very long tear like I did here. But let's try something else. If I get another piece of paper and I start my scratch, but now I'm going to bend my flap forward. I'm bending it forward, creating a flap like in the upper half of the screen here. It's my drawing. And then I'm going to start pulling it down. You see, I'm creating a tear with the least amount of effort. The least amount of effort. Because now, when I put my flap down here, now I'm tackling point A alone, point B alone, point C alone. I am tackling every point of bond between the tissues separately. So I am using the least power. I'm using the least power to create my tear. And less power means more control. Less power means more control. So back again to without my camera. So shearing is the best method to create a tear in the capsule, in the capsule, because you are using the least power. You have the highest control. When you have the highest control, you can control your rexes, extend it left, right, take it wherever you want. How do you prefer to do your rexes? I would like to ask people about this. Do you prefer to do your rexes with a cystotome or with a forceps? If you prefer a cystotome, please press yes on the side, and then you start taking your flap. You press on the anterior flap, on the anterior anterior capsule, and you drag it. And this edge is the edge of the flap. This is the lens matter. This is the edge of the flap. It tells you where the rexus is going to be. This is where it's going to move. So when you pull it in an arc direction, you start pulling it in an arc direction, it starts giving you the circular. And this line tells you where the rest of the rexus is going. As long as you're taking this line to this way, it's going to follow you. This is going to follow you anywhere. Okay, a critical point is when you press from a far distance like this, you ensure to yourself that you're not pressing too hard here and you're dragging the lower part of the flap. If you're dragging the anterior capsule itself, not the flap, like if you press too hard in point Z, if you press too hard, then you're not only dragging the flap, you're dragging the capsule under it. And if you're dragging the capsule, then you're not doing the shearing movement. You are actually doing a tearing movement. And I will demonstrate this in a surgical step in a minute. In the ripping, it's a totally different strategy, because now you're not using the shearing to this direction. You're going to be dragging centrally. You're going to be dragging centrally and waiting for that equivalent force to take you to an arc, like exactly like in this drawing. You drag to the center. You drag to the center. You hold from here and you drag to the center, and then the rexus follows in an arc. And as you can see, you can combine both techniques sometimes. When you're doing your shearing, sometimes if the rexus extends, to use shearing alone to retrieve the rexus here, it's going to work, but it's going to take a long distance. And if you're going, it's going to go in a circular way, and it's a long distance. And if you're already near to the zonules of the equator, that could be an extension backwards. So what you need to do is do the ripping. When you do the ripping, as we demonstrated on the piece of paper I've used right now, you pull centrally, and then it retrieves backwards. You pull centrally and it retrieves backwards. As you can see, I regained shearing again after I pulled centrally, and then this curve came back to me. Now, there's another way, which with the ripping, I want to demonstrate it to you. Let me open my camera again. Now, if I do my shearing and it extends from me, so it's extending. Oh, I'm still doing the virtual thing. Sorry. Okay, now you can see me. So if I'm doing this, if this is an extended rexus and I want to retrieve this rexus backward, what I do is this is my flap and it's going down there, and then it extended this way. Oh, it's extended. Okay, so I want to retrieve it. So either you use the ripping and you go this way and it comes back to me, okay? Or I can use a different method if the extension is too far. I've extended too far, and now I need it back. I need it really back now, not after a minute or so. So it's extending and I want it back. What I would do is, my flap, I take it backward to its original side, and then I pull it in the opposite direction. I pull it in the opposite direction. And when I pull, I don't want the break. Let me demonstrate it. I'm doing my shearing, okay? And then it trips. It extends, and I want it back. If I pull, I take my flap back to its original place, and I pull in the extreme opposite direction. There is absolutely no way to go except vertical on the point of division. Vertical. So to look at my drawing, if I'm here, I will take this flap backwards here to its original place, and I will pull in this direction. If I pull in this direction, this will come back this way. Vertical to this line, it will come back this way. Exactly like, you see my paper? It came back exactly vertical. It came back vertical, okay? Because there's no other direction it can go back from, right? So this is the three methods to put in mind, or the three mechanics that we put in mind while doing our rexes. Now, I'm going to show you a rexes that is demonstrated on our simulator machine, which is supposed to be the optimal way to do a rexes with a shearing. You fill your viscoelastic, as we said. You go to the other side, you fill it, and then you withdraw backwards as all the fluid is leaving the anterior chamber. And now the anterior chamber is fully filled with our viscoelastic. And now you take your scratch, you pull it towards you, and you create your flap. At this point, you can use your acetone, or you can change to your rexes. And rexes can give you a good control. And then you start taking your flap and constantly putting it above the anterior capsule. Constantly leaving it above the anterior. So now you're doing a shearing movement. You're taking the flap and moving it, and you have a mark on the anterior capsule. On our simulator, it gives you a mark so you can follow. And you are moving the anterior capsule directly on top. Your flap is moving directly on top of the anterior capsule, so you make sure that it's constantly. And now you do a ripping movement, and you're done. Okay? So I'm going to demonstrate rexes, my rexes, how I do my rexes. I do my rexes from the sideboard. This rexes gives me, like, I've been using this technique for more than 10 to 12 years now, and this technique gives me a reproducible result every time. Every case you're going to do, you're going to have exactly the same result. So what I do is I open my side ports, fill with the viscoelastic, and then I create my flap centrally, and then I pull it. As you can see, I'm pulling my flap here. create the flap, and now the flap is lying on top of the anterior capsule. As you can see here, this is the rexus, and this is the edge of the flap. I hope this is visible for you. And as you move slowly, every time you move, the edge of the flap is telling you where the rexus is going to be. The edge of the flap is following, is leading the rexus. Very gently, very slowly, and very surely. And this will give you a rounded rexus with a reproducible result that will happen every time you do it. Now, if I want to show you on this case again, this is another case. I do my scratch, push it, create my flap, and now the flap is lying, and you can see the edge of the flap and the rexus follows. The edge of the flap and the rexus, and I keep a distance away from the fold itself. The angle of the fold, I keep a distance from it. So now even if I press on the anterior capsule, my pressure is ineffective or are not affecting the edge of the rexus that's moving. And now I have a rounded rexus, a reproducible result that will look exactly the same with every case. Let's see this one. very deep anterior chamber. Pressure in the anterior chamber is maintained. I'm coming in from the side port, no leaking, nothing comes out. This is end of my rexus, and it's a reproducible circular rexus as always. Now, to show the tearing technique, this is how it looks like. You do a box movement. So the first movement is left and then down, and then you take the down and go right, and then you take the right and go up, and that's the end of your rexus. You have a rexus by now. This is a very efficient technique, okay, and it's reproducible also, but it needs training. For a starting surgeon, I really would want you to do the shearing. The tearing technique is a quick way to do the rexus, and all the quick surgeons, the surgeons that perform fast surgeries, they use the ripping or the tearing technique. But if it has more chances of tearing away and extending out of the of your way. So you do a box movement. One movement gives you an arc. The other movement gives. Then you go on with your rexus forceps, and as you will see, it's a box movement. Grab your flap, and then you're going to go this way, and then up, and then left. Make sure that you're sorry, it's too short. Let's do that again. Let's do the rexus forceps. I'll show you the rexus forceps move. So you pull, you go left, right, sorry, and then down, and then re-grasp and go left, and then out, and your rexus is full. Okay. Now I will show you combining the two techniques of shearing and tearing, the one that I just described a few slides ago. When you start your rexus, and your rexus is small, and you want to do a tear in it to extend it a little bit. So look at the edge of the rexus here. So my flap comes here, and I'm dragging my flap, as you can see here. And now it's too narrow. So I'm going to go to the edge, as I said, and pull. And you see the notch that I did here? Now it's bigger. You see the notch here? Now my rexus is wider. I don't like it still. I want it in it. So I do it another time, and I make another notch. And then I start pulling from the other side, doing my normal. I'm going to show you a case of Argentinian flack tear. In this case, you start your rexes, and the tension inside the capsule is very high. And once I go in, I inject, and you can see it's extending, and that's it. I didn't even get the chance to aspirate anything from inside the lens, and it just extended. In another case, I've taken it, make it the rounded edges, and then I continued my surgery. In this case, as you can see, we didn't open the ports in the back. We had a very full anterior chamber, but still, once the anterior, well, that's it. That's it. It was bam. You have the Argentinian tear with no compromise for it. But of course, because I was intending to do vitrectomy at the time, so it wasn't a big deal. Just made 2 rounded edges, and then I performed my phaco, because what's the worst that can happen? I'm already in the bag. Hydrodissection. I'm going to do the part of the hydrodissection. I'm sorry about the videos of the rexes, but hopefully, yeah, I demonstrated enough. Okay, in the hydrodissection and hydrodelineation are critical parts of your surgery because they affect your load, which is the amount of pressure you are using on your use. So in hydrodissection, you go under the anterior capsule, and then you inject, and you watch for a wave of fluid to pass by to the other side, and you can see the wave of fluid, and then you check the hydrodissection by rotation, and then you dip yourself inside and inject to do hydrodelineation, and then you can see the golden ring, and you pull to one side and see the this shadow arcs here, and then you have the hydrodelineation check also. Let's see this in a surgery now. I finished my rexes. I go inside, I press, and I can see the wave. Did you see the wave is moving? Again, I go under the capsule, and I inject that inside under the capsule, and then I do my rotation. Now I have the hydrodissection full. I do my hydrodelineation, you see the golden ring, push it to the sides, and then you have a full golden ring, and you have hydrodissection and hydrodelineation. Hydrodissection dissects the lens capsule, the lens matter from the lens capsule. Hydrodissection dissects the lens matter from the lens capsule. Hydrodelineation takes your epinucleus from and cortex from the nucleus. So when you're dividing your nucleus and taking out quadrants, the load you are using and the power of vacuum that you need to take out a piece makes it much easier and small and less energy needed. One more time, hydrodissection and hydrodelineation. It's a critical part of your surgery also, because it makes everything easy. You can rotate your lenses and you can see the wave of move, and then I will go now and make sure it's complete. I check it by the rotation. Now it's rocked and rotated. I will do the hydrodelineation now. Okay, now it's rotated. I will go inside and I will do the hydrodelineation. You can see the golden ring. It's a bigger ring this time because it's a bigger nucleus. And then you have it. You have a ring, and we've completed our delineation. And you can see the golden ring, but it's a bigger golden ring. You've completed the delineation and the hydrodissection. I'm not going to get a chance to talk about the phaco techniques this time, but in the next session, I will be discussing the divide and conquer, the chop with a horizontal or vertical, and the variations of both, and using both of them in our next lecture. I think I can take some questions now, anything concerning what I've just demonstrated. Anybody has a question, they can raise their hand, and
I can take some questions now. I have 10 minutes for questions. Okay. Dr. Muhammad Salah.
السلام عليكم.
Salam.
عندي سؤالين يا دكتور. In case of Rex's extension, you will towards the center or in the opposite direction of the extension? This is the first question.
Both of them will work. You pull towards the center if the extension is not too far, if it's medium, like it's a medium extension. I think I had a video here, but I can't tell which one of them for the extended. I think I have a video for the extended Rexes here. If the extension is too far, then you need to pull on the opposite direction. Like take your flap to the original position as if you don't have a flap, and then you pull directly to the opposite direction. If the extension is midway, and then you can use the center, and it will give you a curved retrieval. But the one I'm showing you, it will give you like a vertical retrieval. You will retrieve the Rexes totally backwards.
Yes, yeah, you should have space for curved retrieval in.
Of course.
Not so far extension. Yes, it is understood. Okay. My second question: what was the fault in cases of Argentina flag sign? What was the fault?
Well, no.
What was the cause?
Argentina. Okay, there's a lot of debate about why Argentinian tears happen. Usually, it's in a cataract that is mature and has lens matter that has extended, and there is a high pressure inside the anterior, inside the lens capsule. This pressure is formed by lens matter behind the nucleus and anterior to the nucleus. And usually, there's one theory that says if you have a very big nucleus that separates the anterior and the posterior part of this lens matter, and for you have to maintain a very high pressure of the anterior chamber to combat or to equalize this pressure when you open the anterior capsule. But there's no Argentinian tear without staining. So the stain also changes the texture of the anterior capsule. So there's a lot of debate about this, and you do precautions. You do take measures like increasing the anterior chamber pressure. Like if there's too much cortex matter, you try to press the nucleus backwards and aspirate some of the cortex and increase the pressure again before you pursue with your Rexes. You make a smaller Rexes, and then you go spirally around it so it doesn't extend. But sometimes you just, as you saw in this case, absolutely nothing. We just made a puncture, and that puncture extended in an Argentinian tear. You couldn't, and the pressure in the anterior chamber was very high. As you can see, the anterior chamber is very deep, so the pressure is very high, and then there was nothing to be done. Sometimes you cannot prevent it.
Okay, thank you.
Welcome. I'll take Dr. Ahmed Samir.
Assalamu alaikum, Dr. Wael.
Alaikum salam.
I wanted to ask about while doing a hydrodissection, the length of tip of cannula, it go far away from the Rex's edge, or it is just beneath it? This is the first one. And second question, while we are doing hydrodissection, it is necessary to press by the back of the hydrodissection cannula on the lip of the main incision or no?
I don't think it's necessary that you'd be pressing on the lip here, because your instrument is inside and it's creating enough space for fluid to come out. The main point is, what I do is I press on the lower lip of the wound to make sure that the capsular cap has left the anterior chamber, and that's a sign that you have removed most of the viscoelastic, okay, or a big portion of the viscoelastic inside the anterior capsule. So what you do is you press on the lower lip of the wound, and that takes your viscoelastic out, and then you go inside. The distance that you travel after the rexes is like 1 millimeter. You don't need to go very far where you cannot see it, and you can't be like on the tip of the edge of it. You go for 1 millimeter, and then you inject, and you don't inject forcefully. You don't inject forcefully. You just need to make sure that your wave is moving smoothly, and that you don't create high pressure of fluid in the back of the nucleus or the lens, because that could rupture your posterior capsule, and that's what we call capsular tension syndrome that can happen intraoperatively.
Okay, thank you.
I'll take Dr. Dildar.
Yes, sir. Good evening, sir. So regarding the capsulorhexis technique, sir, you don't mention the technique of the spiral capsulorhexis, that using the rhexis forceps and start concentrically from the center in a spiral manner, increasing your rhexis tube.
I just mentioned it right now. I didn't get a video of it, but I just mentioned it right now as one of the techniques of preventing the Argentinian plaque there.
Yeah, I think this especially is important for the beginners, that they learn take-off.
You mean in all
for the first time, because they give them more control over rhexis.
Are you talking
They give
about
them more control over the rhexis.
Okay, are you talking about using the spiral rhexis for normal rhexis or for the Argentinian tear?
No, for every case, for beginners, and especially for those who have intermittent cataract, to prevent this Argentinian plaque.
Okay. I would definitely recommend this.
Okay,
I would definitely recommend this for the prevention of Argentinian plaque tear, but I would not recommend this for a beginner, because once you start the second circle, your anterior capsule flap is going to be a very thin flap. It's like peeling an orange. The flap is going to be a very thin flap, and once you start dealing with a thin flap, then you're going to be doing like 3 rhexises. You're going to be doing the rhexis 3 times. No, I would recommend, if you're a beginner, I would recommend to follow the technique I've just shown right now. It's a very reproducible technique. Every time you do this technique, you will get exactly the same results. Use the shearing. Use the side port with a cystotome or microrhexis forceps, and try it, and you will find that your hands anatomically are aligned more anatomically. I will open my camera again to show my opinion about my hands. So it's if you're trying to do your rhexis from the 12 o'clock or the 2 o'clock or the 1 o'clock, 11 o'clock positions, your hand is like this, okay? This is not an anatomical position for your hand, like comfortable anatomical position for your hand. But when you put your hand like this and you're going from the side port 3 or 9, this is a very anatomical comfortable position, and you can move, because the shearing movement is a very fine movement, and it's like you're moving as a feather. So you can do it from the side ports. Try it, and you will not regret it. It's a very good technique, and it's reproducible, and you can always get exactly the same results in every case. And my residents, if any of them is here, they've seen me do all my cases, and all my rhexises look identical and exactly the same.
Okay, thank you very much, sir. Thank you.
Dr. Omar?
Hello?
Yes.
In the beginning, great thanks for Dr. Wael and all the participants. I have 2 questions, please, Dr. Wael. First, about the rhexis. I am doing the rhexis from the main wound because I'm using the forceps. I have sometimes problems from the subincisional part. What do you advise with this? This first question. Second one, during the hydrodissection and delineation, sometimes the nucleus doesn't rotate. Is the problem in the dissection or mainly the delineation? And if I put
this is dissection. You have to do dissection from several points to make sure that your wave has moved. And every time you do a dissection, you have to gently make sure that you make the fluid that has accumulated in the back of the on the posterior capsule, in front of the posterior capsule, you make sure that this fluid has come out.
So if it doesn't rotate, it's mainly dissection.
Definitely, it's dissection. Definitely, it's
Yeah,
dissection.
okay.
Don't use violence with it because you have zonules that this is zonules that's resisting you, so or that's keeping the capsule in place or the lens in place. So you need to do multiple points hydrodissection to make sure that eventually at the end the whole cortex is dissected from the lens capsule. The first question was the sub-incisional rexus. Well, if you're using the rexus forceps, what you need to do is when you reach the point of 2 o'clock here or 10 o'clock here, then you should never release your capsule. You have to take the one transverse stroke. You have to take one transverse stroke that will give you the whole curve, and you don't take a small stroke and then stop and try to grasp again. Trying to grasp the capsule under the incision is an impossible mission. So you reach the point of 2 o'clock, and then you grasp your rexus, and you go to the transverse position that takes the whole arc this way, and then you take your flat again, and you take it the upper, the forward movement that takes you the other arc.
Do you see it's better to do from the side port other than the main one?
I definitely recommend the side port. I don't do any. I haven't done any rexus with a rexus forceps for like the past 12 years.
Yeah. Okay. Thank you very much, Dr.
اخر سؤال بقى عشان انا وقتي عدى، اخد دكتور احمد دكتور احمد.
الو
احمد.
الو
يس.
انا دكتور وائل، ازيك؟
اهلا وسهلا.
Thank you about your great presentation. Thank you very much. I have one question.
Okay.
What you are going to do in cases of the posterior polar cataract hydrodissection? Any special
complete hydrodissection in posterior polar cataract is a very dangerous thing to do because you will blow the posterior capsule. What you can do is you do spokes of dissection that you make sure it doesn't reach the posterior part. Sometimes you don't have to do that, but this is what you can do: is you do spokes of hydrodissection that reaches only the mid periphery here, and then you use a direct chop technique. Usually, a vertical chop technique is a better technique, so you don't have to do any rotations. Or you can do the V technique, and that's an advanced thing. It's not V. I don't want to discuss it in a primary course like this. So main thing is don't do normal hydrodissection into the anterior capsule. Normal hydrodissection if you have a posterior polar cut. No, don't do that.
Thank you very much, Dr. Wai. Thank you very much.
Dr. Tawfiq, I think I've overexceeded my time. I'm really sorry.
Dr. Wai, thank you very much. Thank you very much for your nice presentation and this beautiful course. Thank you very much. Can you answer my question, please, if you don't mind?
Of course, yes.
Do you recommend in your capsulorhexis to have an optimal size 5 or 5.5 in all cases, or in case of like soft cataract make it a little bit larger, or in hard cataract make it a little bit smaller, or you do just an optimum size of capsulorhexis?
I go for the optimal size all the time, 5 millimeters. I'm comfortable with it. I do it, and how hard my cataract is controls my technique of phacoemulsification. If I have a problem with the zonules, it still affects my technique of phacoemulsification. My rexus is usually the same. I don't recommend smaller because smaller is going to make your surgery terrible, and it's going to jeopardize phimosis later on, and it increases the chances of having more PCO And a larger one also increases the chance of having a PCO because it's not coacted on the IOL. So an optimal size is the best, and I always go for 5.
Okay, thank you very much, Dr. Wael. Thank you very much for your presentations. Okay, thank you very much, Dr. Wael, for this nice presentations. And also, we will have Dr. Wael, inshallah, next year, and next week, sorry. We will give the course of the third part of FACO course. Now, I would like to welcome again my dear prof, دكتور احمد مصطفى عبد الرحمن، وانا برضه بقدم خالص التعازي لحضرته وشكرا جزيلا لانضمامه لينا بالرغم من الموقف اللي حصل، وربنا يرحم المغفور لي وان شاء الله يسكنه فسيح الجنان. دكتور احمد مصطفى، اتفضل معانا يا فندم.
السلام عليكم دكتور محمد. Thank you very much. Good afternoon, everybody. It's a great pleasure to be with you in this very successful full conference. And actually, I used to hear single talks, but the full conference prepared in this way. So thank you to Dr. Muhammad Tawfiq and the friends, of course. They are doing tremendous, very fruitful work. Thank you very much, and thank you for your words, for your blessing words. And actually, I need this at the moment. I need also the prayers to my uncle, because he was a great man, really. Thank you very much. And I will move now to the my topic. And before I yes, continue. Yes. Before I start, I just want to express my happiness of having friends and colleagues, brilliant friends and colleagues participating. Dr. Wael Gindi with his excellent presentation, and I'm expecting excellent talks from Dr. Walid Tamsawi and Dr. Magdi Musa. So that it's a great pleasure to have such a nice gathering. Today I will focus on the management of primary glaucoma. And I mean primary glaucoma, just primary glaucoma. It is just a short bio that I'm a professor of ophthalmology in Cairo University and a glaucoma consultant, and I am the founder of the Egyptian Society for Continuous Ophthalmic Education, a society that I'm really so proud of it and its performance. And I'm also the owner of the Giza Specialized Eye Center, which is a center for glaucoma management and education. And now we are in the era of COVID-19, so that how do we fight this? We actually fight this through science. So that's that this is our job, and that's what we are really doing. That to fight to enrich our knowledge in ophthalmology. And I think what's happening nowadays is a very decent way of delivering information. And now, before we start, Dr. Muhammad, can we go for the poll questions?
Yes, which one you want, sir?
Let us start. How frequent do you see glaucoma patients?
Okay, now I'm launching the poll in front of you, dear ladies and gentlemen. My colleague, please make a voting.
Interesting. So the majority could see glaucoma patients so frequently. Interesting. And none of the responses that I don't see. Yes, yeah. Very, very reasonable.
In the poll now, we have about 58% share their experience. 60% they say we have a very frequent see glaucoma patient, and 40% they say occasionally.
Interesting, great. Let us move to the second question, please, Dr. Muhammad.
Yes. Regarding how do you often perform gonioscopy? The poll again in front of you, dear colleagues. Can you vote?
Yes. So how often do you perform gonioscopy? Interesting. To every glaucoma patient? No, I don't do gonioscopy at all. Yes, I do, but not to every patient. Okay, that's quite interesting. So that I see the majority is that. Let us see the results, Muhammad.
Yes. We have about 60% share with us their experience. 47 say that they do to every glaucoma patient. 32 they say no, they don't do gonioscopy, and about 54 yes say yes, but not to every patient.
That's very interesting. That's a very good introduction to the lecture, actually. So for the third question, adherence to therapy in primary open-angle glaucoma is almost 90%. Is this a right or wrong statement, do you think? For the patient's adherence to therapy means that they are using the therapy exactly as prescribed. Yes. Okay.
Now the results about 43 say false. This is a false statement. 35 say it's a true statement, and 22 say they don't know.
Yes, this is very realistic. Okay. Then let us move to the fourth question, that chronic angle closure glaucoma is by an acute attack of angle closure glaucoma. Is that right or wrong?
So the results are about 60% say it's false, and 30% say true.
Okay, good. And let us move to the last question, that trabeculectomy is the best management option for patients with chronic angle closure glaucoma. True or false, or I don't know. Yeah. So true and false are always in a competition.
55% they say it's a false statement.
Okay, good. Now let us move to the presentation itself. Now, the aim of this presentation is just, we have a lot of knowledge, and then when it comes to practice and application of this knowledge, it's not always the scenario, because you can know a lot of information, but you apply the wrong information in practice. So that what I really see, that's the biggest problem, that a lot of knowledge, then when it comes to the implementation, then we can get troubles. Then, and the aim of this lecture actually to get you to what I really do. I'm a glaucoma consultant. I just want to share you the experience, what I'm really doing regarding the glaucoma patients, and hopefully we can get a consensus together. The lecture will focus on primary glaucomas, and I mean glaucoma, a patient with established glaucoma, with elevated intraocular pressure, and with glaucomatous optic neuropathy with functional and structural damage. So there is no confusion about that. An established glaucoma case, and I mean primary and absence of a secondary cause for glaucoma, and it's not a refractory glaucoma, but it's just a straightforward glaucoma. So it's a case like that, a patient presenting with glaucomatous optic neuropathy and elevation of the intraocular pressure with the structural and functional defects. Very straightforward case. I'm not going to talk about cases regarding the confusion diagnosis or if the patient has glaucoma or not. No, this is not the mainstay of my treatment. So this is not the mainstay. A patient with recurrent glaucoma or secondary glaucoma, neovascular glaucoma, no, they will be presented in another lecture. So when I have a patient just sitting in front of me having elevation of the intraocular pressure and the disc is cupped, and then probably is having the functional and the structural results as well, then before I put final decisions, I need to dilate the pupil, because there are some conditions which could be lost if I'm going to misdilatation of the pupil, like early exfoliation like that. This is one of my patients. Then you can imagine if the pupil is narrow, then you will make sure that being pseudo exfoliation, which is really a secondary type of glaucoma, and it's not primary glaucoma. And then what's next? Next is gonioscopy. Gonioscopy is quite important in the field of glaucoma. We need to master gonioscopy, and you can also video your patients and enjoy the appearance of the angle like that, like what I'm doing. You can go to the photography or video. Then I have a set of lenses. This is the 3 mirror, and this is the 1 mirror gonio lens, and this is the Latina lens used for laser trabeculoplasty, and this is the 4 mirror gonio lens. which I really like very much. We have different forms of that. So this is the set which I'm using all the time on all patients. And the classification of glaucomas into open angle and angle closure is of critical importance, actually. Hello?
We can hear you, Doripo. It's very clear.
Yes. Yes, it is just the slide is not moving forward.
Just
okay. Okay, so it's the condition is like that. When you have an open angle or angle closure glaucoma, it looks like a crossroad. So with different destinations, so that we need to know that piece of information. Yes, and this is the picture of open angle glaucoma just for invasion. We will see the Schwarz line, sometimes it's pigmented. So Mohammed, you hear me?
You hear me? You are stop sharing now. Stop sharing.
Okay, I'll see that.
We can hear you very quiet, very good, but no share screen.
Yes. So now this is the angle of open angle glaucoma, where we can see the Schwarz line, which is the termination of the desmoid membrane, and then we can see the trabecular meshwork, which is the circumferential structure. This is very important landmark. Then you can see the scleral spur, the white line, immediately below the trabecular meshwork, and then the ciliary body. Of course, we can comment on the shape of the peripheral iris as well. Now, this is an angle closure, so now you can appreciate the difference. We can't see anything. It's just the iris and the cornea. This is, of course, this is the most obvious form of angle closure. And now this is the differences with the open angle and the closed angle. So there is no way to mistake those two angles. And again, there is a crossroad here, which is very critical for the decision. If the patient is having narrow angle like that, we need to do a kind of indentation. That's why I like the 4 mirror lens. It indents the center of the cornea, and at that time you can see the trabecular meshwork. That will differentiate between just a positional closure, or just the peripheral of the iris is coming close to the trabecular meshwork, or there is a synovial closure where the iris is adherent actually to the cornea. So now we're having open angle and angle closure glaucoma, and to the left you can see how the open angle looks like with the deep or normal anterior chamber. And again, we don't depend on Van Herk method, which evaluates the anterior chamber. I know it can guide you, but it is not perfect in 100% of patients. You need to do colonoscopy. And this is the condition in open angle glaucoma with the pathology here. For the angle closure glaucoma, we are having shallow anterior chamber, and the pathology actually is here, where the iris is very close to the lens and the aqueous is accumulated in the posterior chamber, pushing the peripheral iris. Now we will focus on the primary open angle glaucoma. If you diagnose your patient, it's just clinical diagnosis, elevated intraocular pressure coupled and the angles are open. Now it's okay, it's a primary open angle glaucoma. Then some factors I need into my consideration for the decision, which is general factors, including the age of the patient, including the positive history of the disease. Is the patient having bronchial asthma? We need to ask specifically about that. Is the patient having tightness in the breath or having actual asthma before giving any medication? You know, some medications are contraindicated. And also we ask about the cardiovascular condition. If the patient is having systemic hypertension, we need to know that, because that will help in the diagnosis and in the management. Then some ocular factors critically important, including the level of the intraocular pressure, and then basic investigations we have, like the visual field, OCT, and central corneal thickness. These are the basic investigations. And then how the optic nerve looks like, and then the ocular surface is also important in the decision making for the therapy. And it's just simply by putting fluorescein strips on the surface of the eye, if you can get on state of the cornea, and you can see the marginal tear strip, so that, and the fluorescein disappearance time, so that with that simple test, you can actually evaluate the corneal surface. Now, after putting all these factors into consideration, you can think, what's my target here? My target is actually to lower the intraocular pressure according to the severity of the disease. And generally, as the disease is severe, you need to get your intraocular pressure to a lower level if you can do that. Generally speaking, patients with early damage of pressure around 20 is fine, moderate damage in the high teens is fine, with the advanced damage in the low teens is fine. But I just want to say a nice piece of information that according to the results of advanced glaucoma intervention study, none of the patients with an intraocular pressure of 18 or less develop progression of glaucoma during the follow-up. So that should be a good news for everybody. Now, the management options for patients with primary open-angle glaucoma include medical therapy, laser trabeculoplasty surgery. I can think in that way. I will start with medications and then I move to laser therapy and move to surgery. This is a very algorithmic way of thinking, which we usually don't know, or it could be non-algorithmic. I'll go for the best for that patient. So I need to think what's the best that suits my patient. Now let us think of this patient. Patient number one, a 55-year-old lady. She's a doctor. She's having a moderate disease with pressure of 28 and 25. Let's start a discussion with the patient with all the possible options here, because she's having a lot of options that we can go through. The patient opts for laser trabeculoplasty. And then what happens is still the patient needs some information regarding how the efficacy of trabeculoplasty, and I need to deliver those information to the patient that we got reduction of intraocular pressure around 18% during the 36-month follow-up. And then that was associated with the marked reduction of the medications at the same time, so that the patient needs that piece of information. What happened, this is the machine, and we adjust the power on 0.7 millijoule. This is the only factor that we adjust. Otherwise, the spot size and the duration, they are all fixed in the machine. And then I take the patient to the machine, and then I will treat the angle. I treat 360 degrees of the angle using 100 shots. And the treatment is actually easy because it's just a visualized trabecular meshwork, and then we start with the trabecular meshwork, and then we can get some bubbles. What happened to this patient? That she received 3 treatments of SLT over 5 years, and now she is on no treatment, and the pressure is 20 in one eye, 16 in the other eye, with stabilization of the structure and function. So this seems a good result, but again, we cannot have such good results in every patient, and sometimes we are having great results in some other patients. And these are some data that support the laser trabeculoplasty. Please, that SLT can be used as a primary treatment or a supplementary treatment. A patient using a lot of medications and wants to reduce the medication, yeah, there is a place for SLT. The point is that give enough time for the therapeutic response, because sometimes you treat and then you want to get an immediate response. Sometimes this is not the situation. You need to wait, especially for the patients who are relatively young. Patient number 2, 60-year-old lady, moderate primary open-angle glaucoma, as you see, and the situation here, and the patient opted for medical treatment. I just offered laser trabeculoplasty and offered the medical treatment, and then the patient opted for medical treatment. And I know with medical treatment, we start with monotherapy. So this is very important. Whatever the stage of the disease, we start with monotherapy. And the piece of information we need to know that according to the potency of reducing the intraocular pressure, we have the prostaglandin, the non-selective beta blockers, then we have the alpha agonist, and then the selective beta blockers, and the topical carbonic anhydrase inhibitors. That's why usually we don't start with those medications. We start with prostaglandins or non-selective beta blockers, and mostly prostaglandin nowadays. So I start with monotherapy, and be sure that the percentage of adherence to therapy is not more than 70% when you are using a monotherapy. So you need to encourage your patients all the time for the use of medication. And the recommendation, not more than 2 bottles, not more than twice application per day. With 2 bottles, you can have 4 ingredients nowadays. So the maximum we have 4 ingredients in 2 bottles. Definitely, you need to follow up your patient. So you can't leave your patient with dryness and pigmentation, and the patient is irritated. You can't leave your patient like that. You need to interfere with that situation. The intraocular pressure is perfect, but the patient, you cannot leave your patient like that. Yeah. With the ocular surface after staining, if the patient is having dryness like that patient, and then you can offer your patient preservative-free anti-glaucoma eye drops, and you can see like that before and after, before using the preservative-free and after, how much is the difference, and the patient appreciated just such difference. The patient with irritated ocular surface due to medication, then you push towards the surgery. This is not bad. The patient cannot tolerate the side effect, push towards surgery. Now, a patient, a female, who is 47-year-old female, she just came with blurring vision. And then we discovered that intraocular pressure is 47 and 40 on no treatment. So it is again the theme of vision. The angles are open, and her father is almost blind from the glaucoma. The patient opted for medical therapy. Then I started to give her medication. Yes, it's okay. And I got a reduction of pressure of 71%. But what happened is progressive elevation of the intraocular pressure, and then we need to go for surgery. And then if the patient is young, remember that patients with juvenile or open angle glaucoma, the majority will need surgery. So that like 85% will need surgery. So you know in advance, these are surgical patients. The patients with young with long history of disease on multiple medications, and the disease is not controlled, then push towards the surgery. Don't wait. A patient, a 30-year-old patient, and then is having disease, push towards surgery. The surgical options we have could be trabeculectomy, as you see, and then the surgery which I really love and I adopt is the non-penetrating surgery, which I will show you a video about that. And then we start by having a phonics-based conjunctiva. Sometimes we do a good diastema, or if the bleeding is not too much, we just give a cold saline and then give the chance for those measures like the pressure, cold saline, and then we can continue. I don't like to do a lot of diastema action because this invite fibro. And then I'm using the crescent blade for the dissection. Again, pushing for saline can push the blood until we are having 2 or 3 bleeders. We can diatomize those directly. Then dissection of first flap, we will get to the cornea. And then we will start fashioning the second flap. That's why it's called deep sclerectomy. We need to get a second deep layer of sclera, and then we will excise. The second flap is just within the context of the first flap. It shouldn't be of the same size, just inside. And then we dissect the deep flap almost to the level of the ciliary body. And then we can see ciliary body at the beginning, there is no problem. And then we continue dissection and leaving a very, very thin layer of sclera. And if we are in this plane, that will take us automatically to Schlemm's canal. And we want to open Schlemm's canal because after Schlemm's canal, we will find the trabecular meshwork that is best relating. So the whole secret of the surgery is to go deep with the dissection of the deep flap like that. And again, the end of the sclera is called the scleral spur. It's a very sharp white line. You need to find this sharp white line, otherwise you are not in the correct place. And this is not something I will show you a case. We can confuse the scleral spur. So this is the scleral spur. Immediately after the scleral spur, we will open the Schlemm's canal. And after we open the Schlemm's canal, what happens is just we will get circulation of the aqueous through the trabecular meshwork, because Schlemm's canal, the structure underneath Schlemm's canal is the trabecular meshwork. So again, we continue the forward dissection here. We just take care, we might damage it. This is called the trabeculodeafnous window because it is just the trabecular meshwork and the peripheral deafness membrane. And by nature, the trabecular meshwork and this membrane is isolating. And now these are the ends of Schlemm's canal. You can see we can introduce a cannula inside the Schlemm's canal. And once we get into the Schlemm's canal, we always get blood coming from the Schlemm's canal because the pressure starts to go down, and we can remove the floor of the Schlemm's canal. That will help further circulation as well. So at this stage, we will cut the deep flap. That's why it's called deep sclerectomy. We apply antimetabolites, and here I'm applying high viscosity agent, and the surgery is usually switched whether to the deep flap or to the conjunctiva. Now this is another difficulty. Just I wanted to show this because here we are dissecting the superficial flap, and it's like a triangle. It doesn't make a big difference whether it's triangular, rectangular, or other shapes. But again, I'm not doing a lot of diathermy because still I can see. And I got to the periphery of the body. This is the first flap. I did not dissect the second flap yet. And I will now start the section of the deep flap. And you know the structure immediately underneath is the ciliary body, as you can see here. So that I will start raising the deep flap. I like to see the gray color of the ciliary body. And then yes, now we can see the color of the ciliary body here. and then we just get above, and then we proceed forward. What happens during the dissection is that we can open the sclera before getting to the scleral spur. Now here, I'm not quite sure if this is the scleral spur, because the scleral spur has to be very fine line, so this is not the situation. Here I expose the ciliary body. What happened, I'll just go above that, leaving another thin layer of the sclera, and then continue the dissection until the Schlemm's canal is open. And at this stage, this is the scleral spur, a sharp white line. Here it wasn't. So now I left the ciliary body without damaging the ciliary body, just we take care of that, and then we open the Schlemm's canal. What will happen here that after we open the Schlemm's canal, the pressure will go down and the ciliary body will retract. So there is no problem with that, and also it might be helpful because the aqueous can go through this defect into the suprachoroidal space. So with that, I feel it's okay. Then I will also remove the floor of the Schlemm's canal because this will add more to the circulation. And then I will cut the deep flap, and you will see the defect is getting smaller and smaller until it almost disappears. So that this is one of the difficulties that we can get, but it is again very manageable, and we can see good circulation as seen in this patient. Now, a patient with cataract and open angle glaucoma. The decision actually have the patient with cataract and open angle glaucoma, we need to remove the cataract because it is visually significant, but at the same time, cataract removal in patients with open angle glaucoma will not result in significant reduction of the intraocular vision. That's why we need to add the glaucoma operation. And here I'm putting my tomato like the trabeculectomy because it's an external filtering operation to just more safer. And then I move to the lens removal and placement of the intraocular lens. And then I will get back to my surgical chart. I have dissected the first flap, then I will dissect the second flap. So patients having significant cataract should have their cataract removed. And if the disease is moderate or advanced, we should do a glaucoma operation at the same time. We should not rely on cataract as a way for removal, for improvement of their pressure. So getting to the best option, patient number one needed FLP, second patient medical treatment, and take care of the complications of therapy. And then patient number three, then I started medical, then I shifted to surgery. Juvenile open angle glaucoma, I started with surgery. Patient with cataract and glaucoma, phaco and glaucoma operation. So to get to the best decision, I have to put some consideration, just like here, the life expectancy, the stage of the disease, the reactions, the adverse reactions of the drugs, and the patient preference has to be put into consideration. The presence of cataract. Get the best out of your option, which means if the pressure goes up after deep hysterectomy, I will just go after this so that I will not put the patient back on medications. No, I have something in my hand to do. And then the status of the other eye and definitely the availability. So this like SLT is not available everywhere, but it's available around you. Please try to get the best out of it. Now, whatever the management option you opt, you need to go for follow-up. And the frequency will depend upon the situation, the stabilization of the structure and function. And I think Dr. Walid Tantawi will give a nice talk about the OCT in glaucoma. You might ask about what's coming up with the open angle glaucoma, some eye drops like latanoprostein bound and Ropressa or nitrosodial, some MIGS with some MIGS appearing and some MIGS disappearing from the market, and a new drug delivery system like putting the prostaglandins as a canalicular implant, and also having the matoprost string, and to have the matoprost slow release injected into the anterior chamber. And this just got FDA and released to the market, and we participated in this study. And we can have some like iStent inserted in the trabecular meshwork and contains a lot of prostaglandins. So that was summary of the open angle glaucoma. Then I will move with you to the angle closure glaucoma to see how do we take the decisions in those patients. Dr. Muhammad, are you following me?
Yes, yes.
Yes, we are all following you, sir.
Great, yes. Now I will go to the angle closure glaucoma because it's a very important topic as well. That's the situation with the frank angle closure glaucoma. Now, to differentiate between open angle and angle closure glaucoma, if you are able to see the scleral spur beautifully, then this is an open angle glaucoma. If you just see the trabecular meshwork, and then this is an angle closure glaucoma, or if you don't see anything like here, it's definitely an angle closure glaucoma. But I think the landmark here is the scleral flare. If you see scleral flare, open angle, otherwise it's angle closure glaucoma. Then I will show you some patients like this patient. She was a lady who developed more than one attack of angle closure glaucoma, and then she underwent a beautiful trabeculectomy. And then in a couple of weeks, the patient developed galloping cataract. Then we have to manage this. And then you can see the situation that removal of cataract in those eyes is not a piece of cake. Now there is an Argentina flab, as Dr. Ware just has shown us. And then I tried to stain, but despite that, capsulorhexis was not okay. And then the surgery is almost a blind surgery. And then I have to remove the epithelium. So that was the consequence of performing trabeculectomy following an attack of angle closure glaucoma, where the patient developed galloping with cataract, and then you need to manage. You cannot. Yes.
Sorry to interrupt, but the screen is not shared.
I'm sorry for that. Is that okay?
Yes, now it's okay, sir.
Okay. Okay. So now this is the patient I was just talking about. The patient got more than one attack of angle closure, and the decision was to do trabeculectomy. And now after a couple of weeks, she got cataract. Now you can see the cataract. The cataract is really difficult here with the Argentina flab, I just have said, and then working in almost a very blind situation. And for that, we have to remove the corneal epithelium to help ourselves a little, so that those consequences are all the result of performing trabeculectomy. Because the trabeculectomy was so successful, but there is a good chance of developing galloping up the cataract. So that was one situation. Now, a 50-year-old patient who was one-eyed and underwent combined phacotrap. He was chronic angle closure glaucoma, and actually this was not one of my patients, but I have some other disasters. But we can see this patient, what happened. The patient came with this situation. Remember, he's a one-eyed patient. He received combined surgery, and what happened? A lot of hypotony, and the iris is completely adherent to the periphery of the cornea. And what happened? The eyes with chronic angle closure, they do not tolerate any kind of hypotony because the anterior chamber is already shallow and the eye is already small. So what happens here that I'm trying to remove the whole necrotic conjunctiva that developed after the use of anti-metabolite. I will try to stop the filtration at all. I got a large scleral flap, as you can see, just manually fashioned, and then I'll put matrix switches to try to fix this flap to the sclera. And definitely, I don't have a conjunctiva that I can push. I need to get conjunctiva, and then I will go inside to remove the iris. And definitely, you know that my heart is beating strongly because I'm afraid of stripping the corneal endothelium itself. So I'm just trying to go as slow as much as I can. If I'm going to leave the iris adherent to the cornea will decompensate that. So I'm just working slowly from one side port, then getting the iris, and then getting to the other side port and trying to separate the iris that's adherent to the cornea. And you can see 360-degree adhesions. What happened in this eye? There was an overfiltration with the anterior chamber already shallow, and then resulted in the formation of extensive peripheral anterior synucleus like that. So now I actually succeeded in reformation of the anterior chamber. But again, this is a one-eyed patient. What happened here that besides cataract, the patient received as well glaucoma operation. Now that's the picture. 1 year after the operation, we're having a formed anterior chamber, and we're having this sclera. So, and here you can see the formed anterior chamber. But again, you know how much is it stressful to do that for a one-eyed patient? That was the picture pre and post. Now this is one of my patients. I did this patient combined phacotrap. And what happened? She got malignant glaucoma in the postoperative period. Then I have to go for anterior vitrectomy more than one time to control the pressure. And you can see this at the trap and this at the intraocular lens, so that she developed malignant glaucoma. And then I did diode cyclophotocoagulation because the pressure was too high after a couple of attacks, a couple of surgeries performing anterior limb. So again, adding trabeculectomy took me to a complication. Again, that was a combined surgery, and the patient required a lot of kneeling in the post-operative because the trap was not actually working. And this is one of my patients, which I was so happy with his combined surgery, but I just asked the patient, please look down. And then when the patient looks down, just you can see that the trabeculectomy is nothing. It doesn't work. So that it looks like if I did not do trabeculectomy in the first place. So that the patient is benefiting from the only cataract surgery. So as an initial management in patients with chronic angle closure glaucoma, starting or adding trabeculectomy. In angle closure glaucoma is actually full of complications. Just we need to remember that, and definitely mistakes are proof that you are learning. Now, what happened in the case number 9, that a 67-year-old male with advanced chronic angle closure glaucoma, the angles are 0, and then the pressure you can see is 42 and 38 under full medical treatment. Then I decided to do phaco and then to help with some goniosiniculitis. That was the appearance, the operative. Now during the operation, the lens here is almost clear. This is not the issue. In patients with angle closure glaucoma, we need to remove the lens if the lens is not clear, because the lens is responsible for that glaucoma. And now I have implanted the intraocular lens, and then I will get the viscoelastic and inject my pole to try to deepen the angle of the eye and deepen the anterior chamber. And then I will take my Swan-Jacob gonio prism and I will try to get to the angle with the spatula and try to sweep the iris from the 360 degrees, getting to expose the trabecular meshwork that was completely 0. So this surgery is called goniosiniculitis, which is followed by injection of air here, because I think injection of air repeatedly will help more in the reformation of the anterior chamber and deformation of the angle. Now this is the picture in the post-operative period, quite interesting. Now I can see the trabecular meshwork and definitely darker areas of previous adhesions, but the angle is at least anatomically open. I'm not quite sure that the physiology how well it be, but anatomically the angle is beautifully open. And then that was what I'm doing in the old days, that I removed the cataract and then I moved for goniosiniculitis. But with the goniosiniculitis, I used the forceps, which I stop nowadays because it is very traumatizing. I go to the periphery, I hold the periphery of the iris and try to strip it from the angle, but I think this is a bit very traumatic to the iris. So I stopped doing that. I only use the spatula. Another situation here where I have just stopped. I did the phaco, I put the intraocular lens, and then I'll go to remove the iris that's completely adherent to the angle and expose the trabecular meshwork. But again, I stopped that kind of practice of using the forceps. I just go with the spatula, just horizontal separation, and then pushing the periphery of the iris. That will help a lot in opening up the angle. Now, this might be another case, which is patients having attacks of angle closure sometimes end up in having the pupil permanently dilated, and this is not good because it will help the reformation of peripheral anticenic. Now, a 40-year-old lady with angle closure glaucoma, just a couple of weeks, and the pressure is now 45 under full medical treatment. The intraocular lens calculation was 26, and you expect from the small size of the eye to have a hyperopic refraction and the lenses that are big lenses. So the decision here is that basically I want to remove the lens. Now that I need to remove this lens. The lens is clear, yes, but the lens is incriminated in the pathogenesis of glaucoma. Now I will follow the rules of Dr. Wael in doing capsulorectus, and that removal of the lens is not very difficult. And then again, you need to keep those eyes pressurized all the time, so that I keep the infusion until I inject the viscoelastic, because hypotony is not good for those eyes. They can develop malignant glaucoma, even intraoperative. So that now I put the intraocular lens, and at that time I used to go with the forceps and try to separate the iris to the angle. And again, I'm applying some stretch because the pupil was really permanently dilated. I tried to fully stretch with my pole, and I could not So that I decided that I will repair this iris because and I think repairing the iris would be helpful to those eyes. So that just I took one stitch and I like the just suture and then force technique, and then I constrict the pupil and doing gonioscopy, and the angle is now opened, and I feel happy. Now I did not perform a direct glaucoma operation. I just opened the angle. I just repaired the iris and the patient in the post-operative period. And interestingly, the patient is enjoying a beautifully controlled intraocular pressure without anti-glaucoma medications now for almost a year. So now this is the process of goniosynucleitis, which is to go and separate the iris that's adjacent to the angle. There is a lot of controversy regarding the efficacy of these procedures compared to phaco. But again, there is some intermediate procedure between phaco and phacotrabeculectomy. I learned from the practice over years that phaco trap in eyes with chronic angle closure glaucoma is a big trap, and actually will put you into many troubles. So that it will take you to unpredictable dark world of complications. The least complication is ineffectiveness. Imagine this is the least complication. Otherwise, you can get a lot of complications like malignant glaucoma, hypotony, peripheral angiosynecdoche. So that again, I'm not doing trabeculectomy. So cataract surgery is replacing trabeculectomy in angle closure glaucoma, and this is the recommendation of the Royal College. So again, just extraction. You can add something else, but it's just length you need to. But what I really do nowadays in patients with closure glaucoma means the pressure is high, having damage to the nerve, structural and functional damage, and the angle is closed. The diagnosis is chronic angle closure glaucoma, similar to open angle glaucoma, but the angle is closed. They are having different management options. Now, I can go for just phaco, or I can go for phaco goniosynucleitis. And if the pressure remains uncontrolled, I can go for trabeculectomy, following phaco goniosynucleitis or phaco. It is just from practice. I have been doing this for almost a couple of years, and none of my patients require addition of trabeculectomy. And according to the literature, to need trabeculectomy, it's like 15%. Very small percentage that you will do. But if you do a trabeculectomy, the eye will be in a much favorable situation because now you have left the conjunctiva intact, and after phaco, the anterior chamber is beautifully formed, the depth is quite good, so you can do surgery on a much better, in a much better situation. But phaco trap, no phaco trap. Nowadays, I don't do phaco trap. So if you want to add something to the phaco, goniosynucleitis or trabeculectomy, again, you can see the differences. The advantages of trabeculectomy that it can safeguard against the post-operative pressure spikes, and if you are using the forceps, you can get iridodad. Otherwise, with all these advantages, flat anterior chamber, hypotony, malignant glaucoma, bleb-related complications, endophthalmitis, questionable efficacy. So that again, adding trabeculectomy, the angle closure glaucoma, I stopped this practice. Actually, I did not regret a single case of phaco alone in chronic angle closure glaucoma. I did not regret a single case of phaco goniosynucleitis, and I regretted many cases of phaco trabeculectomy, and definitely of trabeculectomy alone in chronic angle closure glaucoma. Now, if we think of the role of the PI in early cases of angle closure glaucoma, now this is one of my patients, a patient of 50-year-old male, and then presented with a moderate disease with chronic angle closure. And at that time, I decided to do the patient PI just to help this patient. And then I'm quite sure that the PI is patent, as you can see from the red reflex right now. And the patient came after a couple of years. What happened? And the patient got progression of the condition. The pressure is 30 and 28, and now I have to put my patients on treatment. The PIs are patent, but those patent PIs do not prevent the progression of the disease. I did the patient OCT, and unfortunately, I found the patients have progressed over those 2 years because the PIs were not so beneficial to the patient. Now, we have landmark studies right now, which is called the EAGLE study. We have compared lens extraction to PI in patients with established chronic angle closure with glaucoma, or even with chronic angle closure where the pressure is 30 and there is still there is no, still the visual field is good. And with those patients, and actually they found good effect of the good long-term effect of cataract extraction compared with the PIs. And then this is another study that the cataract surgery is even much more beneficial. So in conclusion, in angle closure glaucoma nowadays, phacoemulsification has largely replaced trabeculectomy and has largely replaced laser PI. So if you can push your patient towards phacoemulsification, that will be quite good. So that again, how can I put such a critical decision of removal, a clear lens, without performing good gonioscopy and affirming and confirming my diagnosis? So again, if I have diagnosed the patient with primary glaucoma, the crossroad here is gonioscopy. So I will go in one direction with the open angle glaucoma. It's basically a medical condition. I have the options of the SLT, of the drops and surgery. So, but it's basically a medical situation. On the other hand, if it's an angle closure glaucoma, then I will go for phacoemulsification. I can add gonio synucleitis if I would like. So again, this is a crossroad. Without gonioscopy, I can confuse options, which means I can have a patient with chronic angle closure glaucoma, and then I can put these patients or subject these patients to just eye drops and surgery. No, this is not a good decision. On the other hand, I can have a patient with open angle glaucoma, and then I do the patient phacoemulsification, thinking that the phacoemulsification will help. No, this is not true. With the open angle glaucoma, we need to focus on the glaucoma itself rather than the cataract. Dr. Muhammad. Can we go for the poll again? I'm sorry for delivering a lot of information because for the interest of time.
Okay. So again, to the poll, we will start again with the first questions, or you want to go for gonioscopy now, sir?
Yes, I think we go for the second question. Okay. We can change that how often will you perform gonioscopy? Can we do it like that, Dr. Mahan? How often will you perform gonioscopy on the glaucoma patient? Interesting. Okay, good. So the question, how often will you perform gonioscopy on your glaucoma patients?
Yes, we can now reach about 71%. They agree.
They will do gonioscopy. Good.
Yes.
Okay. Now, for the third question, I think they answered it beautifully because the adherence to therapy in primary open angle glaucoma is not more than 70%, and that the majority have said that's true, yes. And then chronic angle closure glaucoma is preceded by an acute attack. The majority have said no. Yes, you are absolutely right. Almost like 20% only will have a history of an acute attack.
So they say it's false.
Yes, they said false. That's true. Because actually, the majority of the patients. Yes, I'm with you. Yes, because they answered correctly. Because the chronic angle closure glaucoma is often preceded by an acute attack. No, only 20% of patients have an acute attack. Because based on that, if the patient did not develop an acute attack, and without performing gonioscopy, you might think that the patient is having open angle glaucoma. So that's the point. But no, the minority they develop acute attack. Then trabeculectomy is the best management option. Can we vote on this last question, Muhammad, that trabeculectomy is the best management option in patients with angle closure glaucoma?
I relaunched the question again. Please vote.
Yes.
Yes.
Yes. The last question, that trabeculectomy is the best option for. Okay, so that I just want to confirm the piece of information in patients with chronic angle closure glaucoma.
I say fault. No, it's not a primary option. No primary. Yes.
Yes. 90%. Yes. Much better. So that's great. Again, so I will start again that we are in this era of COVID, which is helpful in many aspects of getting such online education, which I think gives a chance for huge attendance and changing of the experience. And that's the way we are fighting the coronavirus those days. And thank you very much.
Thank you very much. for this nice presentation. Can we take some questions from the audience?
Yes, please. Yes.
Dr. Ahmed Ismail.
Hello, sir. Thank you for the presentation. It was amazing for me to have such a lovely and interesting notes. Actually, one point about you doing the gonioscopy for every patient with the glaucoma is a wrong statement, because we know that in the early, every new diagnosis, every new glaucoma, really we do the gonioscopy. But for example, the patient visits you after 1 week, after 1 month, we don't need to do gonioscopy. So it's a little bit a wrong statement about to do a gonioscopy for every glaucoma patient. And another thing, the hypogoniosynostosis was something new for me, and I haven't ever tried to do that, and it inspired me to do and to change my protocol. Thank you very much, sir.
Thank you. Thank you very much for your comments. But you know what happened? They are selling the disposable gonio lenses, and the aim of these disposable lenses that you do gonioscopy, then you give your patient these lenses, because the appearance of the angle doesn't change with time. Because, for example, you did your patient, your patient's chronic angle closure glaucoma, and then you did a management, phaco or phacogoniosynostosis. After a while, you might need to have a second look on this angle, so that again, for a patient who the open angle glaucoma, but with time he's having cataract, and so that the angle might change in configuration with time. So that I agree with you partially that you might not repeat the gonioscopy on already diagnosed patient, but sometimes you need to do those.
Dr. Ahmed Khalaf, unmute yourself, please. Dr. Ahmed Khalaf.
Yes. Thanks a lot, Dr. Ahmed. You, as usual, you impress us by each talk you do. Thanks a lot for your effort. My question is, yes, for angle closure attacks, it's usually that we should do the emergency treatment for it, and after stabilization, then we go for treatment. But it's clear for those who have cataract over 40 that we would go for phacoemulsification. But what patients under 40 or their cataract, whose cataract doesn't affect their visual acuity or even has no cataract, would we still go for phacoemulsification, or we will be hesitated a bit?
So Ahmed, your question is a patient with chronic angle closure glaucoma, and the patient is below 40, yeah?
Oh, sorry, no, actually, angle closure glaucoma. Those who don't.
Attacks of angle closure glaucoma?
Yes.
And the patient, yes, that we see those, the severest form of angle closure patients with gland of Town, and you can see those patients with, they are having plus 20 flushes also, but they don't present with an acute attack. But let us go back to a patient with a straightforward situation who is having an attack of angle closure glaucoma and below the age of 40, yes? And I think for that patient, you need to work more to exclude the possibility of plateau iris syndrome, because yes, angle closure glaucoma is common in a bit elder age, but a patient with below 40, and for those patients, I might like to do PI. If the pathologist primary angle closure glaucoma, just PI, and then before doing the PI, I might like to do UBM to see the configuration of the peripheral iris, if there is an evidence of plateau iris or not, because this could be a factor as well, Ahmed, in those eyes. And if the pressure continues to be uncontrolled or to get attacked after the PIs, I would go for cataract surgery then. Yes, there is a chance, I know, for a peripheral iridoplasty, but I think I will go for cataract surgery.
Thanks.
Thank you, Ahmed.
Thank you, Dr. Ahmed Khalaf. The rest of the questions with Dr. Ahmed Yahya. Dr. Ahmed Yahya, please.
Thank you very much, sir, for your informative lecture. My question is about if you have a patient with cataract and advanced case of angle closure glaucoma, what's your plan, or what do you do for this?
Thank you for this question, Ahmed, because those are the majority of our patients. What happens that those patients, they continue to deteriorate under medical treatment because they are treated as being an open-angle glaucoma, and actually they are not, they are angle closure glaucoma. And then they come to you at the end stages of the disease. And what happened with those patients, I just spent time with them that we need to do surgery that includes removal of the lens, even if the lens is clear. So that I do a gonioscopy in the first place, and then I go for removal of the lens and do goniosyneclysis. And then in the post-operative period, I put the patient on systemic carbonic anhydrase inhibitors, and I evaluate the response to surgery. And I just want to let you know that those are the majority of my patients, and they benefited a lot from that protocol. And you can, if you want, you can put your patient back on one bottle of medications. But again, being advanced disease is not a contraindication to surgery. And even more, if the patient is having advanced disease, you might be afraid from hypotony. So that if you have to do an operation, you're still avoiding hypotony. You know, with goniosyneclysis, it's impossible to have hypotony post-operative. You can get some pressure spike, and that's why you give carbonic anhydrase inhibitors, and then evaluate your patient if he's going nicely or he needs another glaucoma surgery under very favorable situations. That's my protocol.
Thank you very much.
You are welcome.
Sorry, sir, the last question for Dr. Labib Al-Jazairi.
Yes.
Dr. Labib. Dr. Labib.
Dr. Labib.
Okay, just for sake of time, we will move to Dr. Mohsen Iqbal.
Yes. Hello. Hello, Dr.
Yes.
Mohsen.
Sir, Professor, excellent presentation, very nice information in a very short time. I really appreciate. I wanted to ask that how do you manage malignant glaucoma in these cases? Because doing anterior is very difficult. Anteriorrectomy, more and more laser is difficult. Should you go directly for pars plana vitrectomy or just laser PI or a rupture of the anterior posterior capsule? Thank you.
Yes.
Thank you.
Thank you, Master. In the first place, you need to avoid malignant glaucoma because, of course, all the management options for malignant glaucoma are not very satisfactory. So that in the first place, you need to avoid hypotony. That's why I don't leave those eyes hypotenuse intraoperative. I keep the infusion all the time. If I'm going to get the infusion out, I put the viscoelastic in. So something has to keep those eyes pressurized. Then in the post-operative period, and actually, I don't do trabeculectomy nowadays, so I don't see malignant glaucoma actually. But if I'm doing combined surgery with that scenario and the patient develops malignant glaucoma, and definitely there is a chance for medical treatment, giving all medications, including atropine. Sometimes these can work, but in the majority of patients, you need to do something. The work here is that you will do a combination of anterior vitrectomy, and usually you can remove the anterior hyaloid and peripheral iridectomy as well, and the posterior capsule in an area. And I have seen my friends doing that. I did not perform myself because I used to do just anterior vitrectomy, and now and also I can help the formation of the anterior chamber with some of diode cyclophotocoagulation because I think that helps in the formation of the anterior chamber. But again, this is a very avoidable situation by avoiding doing trabeculectomy.
Thank you very much, my dear Prof. Dr. أحمد مصطفى عبد الرحمن، وأكرر تاني خالص تعازية لحضرتك يا فندم.
الله يخليك يا محمد، شكرا جزيلا.
بشكر حضورك معنا بالرغم من الظروف اللي حصلت. Thank you very much for you. We wish you can join us again in the next week إن شاء الله.
Sure, my pleasure والله يا مازن. يعني my best wishes, my best sincere wishes for this tremendous efforts in doing such an interesting, very useful online activity. I'm really enjoying the education this way. Thank you, Muhammad. وربنا يوفقك يا رب. Thank you very, very much.
Thank you very much. So again, my colleagues, thank you for Dr. Ahmed Mustafa for sharing his experience and his beautiful lecture with us. Now I would like to welcome all of us with Dr. Walid Tantawi, ophthalmology consultant from UK. He will present for us a keynote lecture about OCT interpretation in glaucoma Dr. Walid Antawi.
Thank you very much for having me, and thank you, Dr. Ahmed, for excellent talk. It's always very difficult to talk after Dr. Ahmed. It's a lot to take in. So I hope everybody is keeping safe. Let me just share my screen. Right, okay. So I'll be talking about OCT interpretation in glaucoma. This will be a basic interpretation talk. There will be, inshallah, another talk at some time later with more cases and bottling cases. I have no financial interest in any of the products. I will be discussing some products in this presentation. However, I'm open to offers if any of the companies would like to offer me something. Right, so what's the role of OCT in glaucoma? It actually provides structural examination. It is objective and quantitative. Quantitative means that it is measurable. It's most useful in early glaucoma as a diagnostic adjunct to clinical examination and disc photography, and for monitoring changes as well in the structure. So it cannot stand alone as a diagnostic tool, as Dr. Ahmed said. So this series of OCT for the same patient over 3 years, this is a glaucoma progression analysis, and we'll discuss this at the end of the presentation. So the RNFL damage was evident before any detectable visual field loss. As you can see here, there is an infratemporal localized RNFL defect, which was observed in the deviation map in the presence of a normal visual field in October 2009. The visual field defect was detected in about almost a year later, in February 2010. These are the different modalities of glaucoma imaging. So there is the OCT, and the most common ones that are in the market are the Zeiss ones, the Stratus, which was the old modality, and the Ceres. And we've got the OptiView and the Topcon. So they are used mainly for the RNFL more than imaging the optic nerve head. It images both the RNFL and the optic nerve head, but it's better to be used for the RNFL. Then we've got the HRT, which is used mainly for the optic nerve head, and this is almost obsolete now, and the GDX, which images the RNFL now. So we'll focus today on the OCT, as it is arguably the best imaging tool so far. A little bit of background on OCT. OCT stands for Optical Coherence Tomography, and it's been around for almost 30 years. In 1991, David Hong, which is a great ophthalmologist, he was a student in Harvard MIT. He conceived the idea of OCT. He's now a full professor of 15 patents and 14 pending patents. He also co-invented the anterior segment OCT and the OCT angiography, which Dr. Magdi will speak about. The OCT uses multiple A-scan and rapid succession, and it compares the reflection returning to scanner from tissue against reference image, as I will show later. The greater the delay, the thicker the tissue. So as we can see here, just the highlighter. Right. So we can see here that here's where the doctor or the technician sits, and the image or the beam moves from here. Then half of it goes to the reference mirror and half of it goes to the eye. Then the beam goes back to the beam splitter, then goes back to the detector, where it analyzes according to the speed. So as I said, the thicker the tissue here in the patient's retina, the greater the delay. So basically, the OCT machine compares the ray that's coming from the patient's eye and the one that's coming from the reference image. That's basically how the OCT machine works. So the types of the OCT are the old time domain, which is the Stratus OCT, and the newer spectral domain or the Fourier domain. And the most common ones that are in the market are the Ceres and the RTView. I'll focus on the Ceres, it's the Zeiss one, because that's what we use in our unit. This is the original technology, the time domain. As you can see, it was very bad. That's a scan from the 90s. It was a very bad resolution. And that's the latest technology, the Fourier domain, the one that almost everyone has now. This is a quick comparison. As we can see, the time domain was operator dependent. However, the spectral domain is not operator dependent at all. The area scanned in the time domain is just 526 points, while in the spectral domain is 40,000 points. It uses a cube, 200 by 200. It's a cube scan. I'll skip the time domain because we don't really have it nowadays. So that's, I'll jump now to the Ceres OCT. It uses a cube data. As I said, it's higher resolution and faster scanning and gives more data, unlike the old Stratus OCT. It's an entire cube of 200. And it examines the optic nerve head and the RNFL around it. Okay, let's go to the practical part. This is the printout. This is an example of a Stratus OCT printout. I know there's a lot to take in, but let's break it down so a bit by bit so we can know how to read it systematically. So we'll start by this area, which is the patient and exam data. In a busy clinic, mistakes can happen, and you want to make sure that you have the right OCT for the right patient in front of you. So just make sure that you've got the right name and the right hospital number and the right date of birth and the right gender. Why is the date of birth important? Because the patient is compared in the machine against a similar age group. That's how the color coding map works. And it's important as well because the machine compares the patient to himself or to herself for follow-up, as we will see in the glaucoma progression analysis. These are two scans on the same day. As we can see here, the technician just changed the date of birth from 1992 to 1929. And the scan, if you look here on the right, for the right eye, it's more or less glaucomatous, but when we corrected the date of birth, it's more or less a healthy eye. So it is very important to double check the date of birth. Now let's go to the signal strength. So the scan quality, the higher the number and closer to 10, the more reliable the scan. And that's where you see the signal strength. That's for the right eye, and this is for the left eye. And for those few who like to take screenshots, that's the time. So signal strength, if it is 8 and above, that's a good signal strength. If it's 6 or 7, is okay. It's not optimal, but you can take it and interpret it with caution and with a pinch of salt. If it's 5 or low, it's reliable. So that's us finished the top. Let's move to the area at the bottom. That's the left eye and that's the right eye. We'll discuss now the thickness map and the deviation map. So the thickness map, which is this one and this one, normally you should see a bifurcated area of hotter color superior to the disc and one large area inferior to the disc. So you should see 2 peaks here in this area superior to the disc if the patient is healthy or if the person in front of you is healthy, and a large area of hotter color, which is dark, either yellow or red. That means that the RNFL is thick in this area. So this double or triple hum appearance is reflected on the RNFL thickness graph as we can see here. So that's the thickness graph, we'll discuss it later. But these areas, the superior area and the inferior area, reflects on the superior and inferior area here, and that's the double or triple hum that we can see. That's for the thickness map. For the deviation map, these two, in healthy eyes, we shouldn't be seeing any hotter colors. As you can see in this patient, no hot colors at all. However, the caveat with the deviation map is that in all different modalities, the normative database is a bit small, so keep that in mind. And it is called deviation map because deviation means deviation from normal. The red color here, if you see any red color, it means that less than 1% chance the results are normal. And if you see any yellow color, it's less than 5% chance the results are normal. So what you want to see is hot colors on the thickness map, this one, and no hot colors on the deviation map. It is important, as I said at the beginning, to correlate the clinical picture to the OCT scan. Here's an example showing focal RNFL defect correlates in the clinical picture to the thickness and deviation map. So if I can remove this, if you look carefully in this area, you can see that there is inferior localized RNFL thinning. And if you look at the thickness map, you almost don't see any hot colors in this area, while in the deviation map, you see hot colors. So you should correlate the clinical picture to the OCT scan. As you get used to looking at thickness maps, you will become familiar with what the normal thickness map looks like for the different age groups. The RNFL tends to get thinner as we grow older, and it may not necessarily mean glaucoma. So as you can see here, this is the age, 14, and this 82. As you can see here, hot colors around the optic nerve head, while here is not glaucomatous. However, this RNFL are very thin, and that's normal. So we finished the top area and the thickness map and the deviation map. Let's move to the optic nerve head and RNFL parameters. The first thing to look at is the disc area. It will always show gray area. As you can see here, it will always be gray. That's because all the disc parameters in all machines, there is no normative data. So someone can have a small disc or a normal size disc or a large disc. So that's why the machine cannot interpret it as normal or abnormal. So a small disc or a large disc can both be normal. So that's why it is always grayed out. However, in large disc, if the disc is large on the disc area, everything else starting from here onwards will be gray. Right. After that, we look at the average RNFL thickness for the right eye and for the left eye, and RNFL symmetry. Right, so this area, sorry. Right. So this area would be for the optic nerve head, and this area would be for the RNFL. This one is the right eye, this one is the right eye, this one's the left eye, and this one is the RNFL symmetry between both eyes. I hope that's clear. So the average RNFL and symmetry, the ones at the top, will always have a color. Symmetry tends to go down with glaucoma. The other disc values, these ones, the cup disc ratio and the cup volume and the REM area, are not really important. They are generally used for monitoring rather than a diagnostic tool. Right, so let's move downwards to the center. So these two are called RNFL and neuroretinal REM thickness graphs. The graphs, the normal results are double or triple hum, as we said, within the green. So as you can see here is the double hum here, and if you see another one, that's triple hum, and all should be within the green. Loss of double or triple hum occurs in glaucoma, and one of these will be the right eye, OD and OS, and they are overlapped here. And here you can see the circular tomogram for the right and the left eye, taking the curve that you can see on the deviation map and plot it into a line where you can access the segmentation of the RNFL bundle. So the whole central part of the scan, just highlight it for you. So the whole central part of the scan, which is this one, the results are compared against the normative database, and the results are displayed in red, yellow, and green. So if you want screenshot for this one as well. The green means that 95% chance of the results are normal. The yellow means less than 5% chance the results are normal, and the red means less than 1% chance the results are normal. However, I don't want you to interpret the scan as a stockbroker. So you should really correlate what you see in the thickness and deviation map to what you see here in the center. For the sake of time, I'll just skip the RT view. It's more or less the same, really, compared to the Ceres. These are two images of the same patient. As you can see, the hot color here and here are more or less the same. A little bit of thinning inferiorly in both of them. So the data presented in graphs and sectors in both machines, 12 sectors here in the, 12 sectors in the Ceres and 8 in the RT. I would like to argue that this is part of the standard glaucoma workup, the ganglion cell analysis. It's more or less new in the newer machines, and the newer machines are able to map the ganglion cell layer. Macular thinning occurs in glaucoma due to ganglion cell loss, and the pattern of loss really correlates with the RNFL loss pattern. It is used to confirm or refute your hypothesis. So basically, if you have a hypothesis that this patient is glocomatous or not, you should take a good look at the ganglion cell layer and see if it helps you with the diagnosis. So this is how it looks like, the ganglion cell layer in the serous and the RT view. This is the area we scan. This is the famous picture from Kansky. So if you have any superior or inferior thinning, it should show here or here. Again, for the right or left is the same. Right, let's go quickly shed a light on the glaucoma progression analysis. It's a software like the one in the Humphrey visual field machine. It will analyze and flag the reading as possible loss, likely loss, or possible increase. You actually need the minimum of 3 scans or 3 exams, but please keep in mind that the signal strength of the scans, like in this example, there is a possible loss. However, the signal strength is 8/10 in one of them compared to 9/10 in another one. So keep in mind that you should have more or less the same signal strength. Let's go quickly through the artifacts that you can see with the OCTs. So you've got algorithm failure. As you can see here. So it's data from that area that the machine couldn't analyze, and it will be shown as black patches in the RNFL thickness map and the corresponding red or yellow area in the deviation map. So just that's why I said it is very important when you look at the scan not to look at the colors only. You need to go back to the thickness map and the deviation map to make sure that the scan was okay. So this is an artifactual thinning in one of my patients. It's not a real thinning, as you can see here. If we just look at the colors, like a stockbroker here, we might think that this patient has got glaucoma. However, if you go back to the thickness map and the deviation map, you will notice that it is an artifactual thinning, is not a real thinning. It's unusual to have the RNFL thinning starting nasally or temporarily, as you can see here. Also, one of the things you can see a very nice double or triple hump here. So that doesn't match with what you see here, right? So all the graphs are still in the green here. When we looked at an earlier scan, that was the patient scan, as you can see. So that's without the artifact. The other one is a blood signal. As you can see in this patient, this is an area of vitreous hemorrhage. In this case, again, it's artifactual thinning, not a real thinning, as you can see here as well. That's another example of one of my patients. He was a glaucoma suspect with vitreous floaters. So let's look here. You might think that that's an early superior RNFL thinning. But if you look at the graphs, you'll see very nice double or triple hump appearance, all in the green. So we repeated the scan, and the floaters just moved a little bit further away from the optic nerve head. And as you can see, very nice RNFL thickness. So the difference between the algorithm failure and the blood signal is that the algorithm failure is usually black area, which more or less looks pixelated, as you can see. However, the block signal is a black area, follows the pattern of the cause of poor signal. whether it is a foreign body or vitreous hemorrhage or floaters. Sometimes it's a combination of both, and it's hard to distinguish between the two. Another artifact is the disc border identification. One of the advantages of the newer machines over the time domain is that it doesn't require the technician to identify the disc border manually, and it uses an algorithm. Sometimes this algorithm fails, especially in tilted discs and in myopic patients. In this patient, the black line in the deviation map represents where the machine thinks the disc border is, like here as you can see. And when you look at the actual disc, it is completely normal and rounded. So this will affect all the data that the machine will represent. Here's an example of one of my where the machine thinks that the right optic nerve head is big. As you can see here, the disc area is 3.2. Okay, and that's what the machine took. And that's the result, more or less glaucomatous patients. But when we looked at an earlier scan, it's actually a small optic nerve head. As you can see, it's 1.33. So please bear this in mind. You have to correlate the clinical picture, if the disc is large or not, to what you have on the OCT scan. So this patient had a small optic nerve head in both eyes, as you can see here. But that's one of the artifacts of the OCT scan. Another artifact we said about the data entry. So if you put the wrong date of birth or the technician put the wrong date of birth, it will give you totally wrong results. So to summarize the drawbacks of OCT, it cannot stand alone, only as an adjunct. Intertest variability and fluctuation. So even if you have the same patient having 2 scans on the same day, it can give you slight fluctuation. Scanning artifacts, hazy media, and there is analysis artifact, usually in unusual disc shape or size. So they tend, the OCT scan tend to fail us in the challenging cases like the tilted disc, where we actually need them. And I will finish with that, and I'm happy to, there was like 3 scans I would like to discuss with you, but I'm running out of time. So I'll just finish with that, and if there's any question, please let me know. Thank you very much.
Thank you very much, Dr. Walid, for these nice presentations. And we have time for 5 minutes to take questions. So please, again, I will ask Dr. Ahmed Khalaf. Dr. Ahmed.
السلام عليكم. دكتور وليد، اولا شكرا جزيلا جدا للمحاضره very comprehensive. I would like just to raise the point of the importance of ganglion cell layer, because you said that it's used as a confirmation for any glaucomatous changes diagnosed through the RNFL changes, where actually ganglion cell diagnosis is, or ganglion cell analysis is used nowadays as an early predictor for glaucomatous changes, especially in myopic patients where they have dented disc or peripheral atrophy. So yeah, I would like just to note that it's nowadays it's even recommended early or firstly the ganglion cell analysis before the RNFL. Thank you.
Thank you very much. So that was a comment, not a question, right?
Yes, yes.
Yeah. Okay. Thank you very much. Thanks a lot. Yeah, we do ganglion cell analysis for all of our patients nowadays. But as I said, I mean in the old software. So those of you who have old software, like some of the machines won't have the ganglion cell analysis. But you can ask the company to update the software for you. Thank you. Any other questions?
Assalamu alaikum, sir.
Wa alaikum salam.
Nice presentation. I have heard you even in Pakistan. I'm from Pakistan. I have heard you in Karachi as well. So nice to see you again.
Thank you very much. Yeah, I think I give a talk in Karachi.
Karachi.
Yeah, that's right. Yeah.
Karachi. Excellent presentation. I want to ask two questions. First, most of the times we get this report and these are done by the technicians. So the main problem what we get is the circle of the optic nerve head is not centralized. So we get report of these mostly in the myopic patients. So what to do for that? First. Second question, in the myopic and highly tinted eyes, should we rely more on ganglionic cell complex or RNFL? One, or they both are equal. Should we both have equal representations for the diagnosis of glaucoma? Thank you, sir.
Right, you're welcome. So for the first question, as I said, the OCT scan tends to fail us in, can you still see my screen?
Yes.
Yeah, okay, that's great. So as I said, the OCT scan tend to fail us in tilted disc and myopic patients. However, I don't disregard them completely. I use them mainly for follow-up. So as a diagnostic tool, it's not very helpful in tilted disc and especially when there is a lot of chorioretinal degeneration around the optic nerve head. So the machine might mistake this as thinning of the RNFL. So it is very important to distinguish between thinning of the RNFL due to high myopia and thinning of RNFL due to glaucoma. However, you can still use the OCT for follow-up in myopic patients. That's the first question. Can you repeat the second question, Dr. Khalaf?
He is not more with us, so...
Sorry, I didn't catch the second question. It was about the optic nerve head and the RNFL, but I didn't really catch the question.
We will move to the last question for Dr. Raka. Dr. Taraka? Dr. Taraka, you are with us?
My father. Yes. Hello.
Hi.
I'm with you. Hello. Can you hear me? Hello.
Yeah, can hear you. Go ahead.
Yeah, thank you very much for the excellent presentation. And I'm joining from Sri Lanka.
You're welcome.
And my question is now, is there a standard acceptable amount of nerve fiber thickness loss for a particular period? Now, just as we are following up patients with the visual field tests, is it possible to follow up with the OCT RNFL thickness like that?
So do you mean follow up with OCT only? Can you stay with me, please? Don't mute yourself. Do you mean
without going for a glaucoma progression analysis software, is it possible for us to compare few OCT reports and decide on the progression? In such a case, how much of nerve fiber layer thickness loss is acceptable for a certain period? Is there a standard thicknesses like that?
Right, that's a very good question. Let me just put a clear one. Okay, so as I said, OCT is used as an adjunct to clinical picture and to visual field. So in our practice, we repeat the visual field once and the OCT scan every visit, because it's a quick non-invasive scan, and this doesn't depend on the patient, so it takes about 5 minutes. So we repeat the OCT scan each visit, and we do the visual field every year. And we correlate this to the clinical picture and, of course, to the rest of the clinical picture. Now, for your question about what's acceptable, there's something called green disease, and I will discuss this later on, inshallah. So if a patient is here, you see the screen?
Yes, we can see.
Okay. So if the patient is here and he loses some RNFL, or there is thinning of RNFL, and the RNFL is here. That's called green disease or green sign. So it is important. It is important to look at the average RNFL thinning. Everything can still be green here, okay, but the patient is losing RNFL. So once you notice that the patient is losing RNFL and it is matching with your clinical examination, then you should start the treatment.
Okay. So how many OCT reports have to be analyzed before deciding?
Dr. Raka, sorry, the voice is interrupted.
Yeah, I get the question. I get the question. So, I mean, if you have even a single OCT with thinning, then you can start the treatment straight away. If the OCT is normal, but you still can see thinning, and there is let's say slight thinning of 5 micron or 10 micron, that can be just fluctuation, but it fits with the clinical picture, like a patient with 38 IOP, for example, with positive family history and narrow angle, you know. So it's the full package, really.
Right. Thank you. Thank you so much.
You're welcome.
Thank you very much, Walid, for this night's presentations and the questions.
Thank you very much for having me.
I wish you will join us again next week, inshallah.
Inshallah.
And stay safe. Please stay safe, okay?
Thanks a lot. Thank you.
Okay. Now, on colleague, I would like, and also all of us, we have to welcome our dear prof, أستاذي أنا شخصيا وأستاذنا كلنا الأستاذ دكتور مجدي موسى. He is a ophthalmology consultant. Please pay attention. Put your seat belt well, because Dr. Magdi Musa will take us in a very nice flight to his kingdom. Dr. Magdi, mic with you now. Welcome, dear prof.
Thank you, Dr. Muhammad, for the kind invitation. Can you hear me well?
Yes, I can hear you very well.
Can you see my screen?
You can share.
Now. Can you see it now?
You can see your camera, but we can't see the screen yet.
Share screen from.
I did share the screen. Let me go again and do share screen. Share. You see it now?
Yes, now you can see your desktop, the whole desktop.
Okay, now the presentation is there.
Now we can see the presentation.
Okay, let me first thank Dr. Muhammad Tawfiq for the kind invitation, and I see a lot of audience, over 500 down there. I enjoyed the talk of Dr. Walid, Dr. Mustafa, Dr. Walid again, and Dr. Wael and Dr. Walid. I've been there for 3 hours listening and knowing the buttons down there, because it's the second time for me on the Zoom. But a lot of buttons down there, and I keep playing with them until I came to my presentation. Thanks for the invitation, and let me introduce myself. I'm Dr. Magdi Musa. I'm from Egypt, Tanta University. I'm the chairman of the department. My specialty is medical retina and imaging. Today, my talk is about OCT in real life practice. Do we need OCTA in everything? Let's go through the presentation. I have no financial disclosure because I'm going to speak about the machine I have the good experience in, which is the Topcon machine, though I don't have any financial disclosure. I have the machine since almost 5 years, in September 2015. Let's go for a quick introduction to optical coherence tomography and geography. We all know that it's a technology, a new one, depending on measuring the movement inside the blood vessels of the erythrocyte inside the eye. So it's multiple line scans on the same point, getting any movement inside the eye. We all know that the only thing is moving is the RBCs inside the blood vessels. So it allows non-invasive visualization of the retinal choroidal vessels by detecting the erythrocyte movement. The picture on the right side, as you see, it's a depth resolution imaging modality. You can see multiple levels, though the machine will segment that in one by one level, but sometimes can get a movie having all the layers, and you can subtract layer by layer, and I think it will be in the future. By this, it will enable us to visualize three-dimensional retinal and choroidal vasculature. And this is the output of the machine. We get a line scan like this with all the layers, and I will show you one by one how the layers work. This is the first layer, which is the superficial capillary plexus, which is bordered by the internal limiting membrane, including the retinal fiber layer and ganglion cell layer. So it's up to the inner plexiform layer. Then comes to the second layer, which is the deep capillary plexus, which is bordered by the inner plexiform to the outer plexiform layer. And each layer has a color code surrounding the cube, as we can see here. The next layer is the outer retina. We know there is no vessels in the outer retina, so it gets black, and sometimes you see white dots like this because of the showing the choriocapillaris through the effect of the RP. And it's light blue. And the last one is the dark blue, which is the choriocapillaris layer, which is limited by Bruch's membrane and the choriocapillaris. So these are the four color-coded areas, which the machine segment automatically and put it in the output, and we can even print it. And we can see the orange, the green, the light blue, and the dark blue. 4 layers. And this is like false color code, which putting all the layers together, so we can see the orange with the superficial plexus, the green is the deep plexus, and the choriocapillaris in the blue. And this is the output, as we can see. This is the output the machine can give you. Superficial plexus, as we see on the left side here. This is the first one. The deep plexus, which is completely different to superficial plexus. I can explain that in a minute. The superficial plexus looks like the plexus we see on fluorescein angiography, where the vessels is coming straight lines, then branching, and then making the surrounding capillaries of the fovea vascular zone. The deep plexus, we don't see it on fluorescein angiography. It looks like vortex or like a head, medusa head, and then branching from it. So it's not exactly like the superficial plexus, it's completely different. And look at this, this is the superficial plexus inside the retinal nerve fiber and ganglion cell layer. If I click on this, and this is the density map, we can see the flow inside this area. If I click here on the deep plexus, it will come the flow inside the deep area, the deep plexus, and we can see it is like accumulation of vessels connected horizontally and vertically. Let's go to the lecture. OCT in real life practice. We all know that a lot of places have OCTA now, but not all of us have it. When should I order OCTA? Should I order OCTA in every retinal vascular disorders like artery occlusion, vein occlusion, diabetic retinopathy? Can OCTA aid in the diagnosis and management of CNV? We know that OCTA is used nowadays a lot in CNV diagnosis, not in the management, but in the diagnosis. Is there any situation that OCTA would be preferred or superior than fluorescein angiography and OCT? And can OCTA be the only diagnostic tool in certain macular disorders? We will answer these questions at the end of the lecture. In diabetic retinopathy, we all know that baseline we do fluorescein and OCT, which is quite good enough for diagnosis and management of diabetic retinopathy. But can OCTA detect changes we don't see by even fluorescein or by microscope or OCT? This is a patient, female, with diabetic retinopathy and her visual acuity is 612, and look at the horizontal line scan. We don't see much of changes, maybe subtle changes in the perifoveal area like hard exudate or hyperplectic foci, but there is no gross lesion over there to explain the 612 vision. So the OCTA is the clue in this case. There is ischemic macular. Though we used to teach the undergraduate that the first changes are microaneurysm, fluid, exudation, and then comes the occlusion and enlargement of the face. On the contrary, sometimes you get the earliest change is ischemia. And let me magnify that. This is the superficial plexus, and this is the density map. You can see how much enlarged the face because of the low flow in the perifoveal area, or we can say capillary dropout. So probably this is the cause of diminution of vision in this case. So again, we can explain why the vision is affected instead of going and not believing the patient or doing further investigation. Proliferative diabetic retinopathy, fluorescein angiography and OCT is quite good enough. We can see here, this is a proliferative case with multiple NVEs. We can see here an NVE, NVA along the arcades, and diffuse macular edema, and it's proved to be cystoid by the OCT. But why the vision is markedly impaired? The vision is dropped to 660. Now, I can use OCTA in such cases to prove what is going on in there. So look at the superficial plexus. This is a 3 by 3 millimeter cube, highlighting the central fovea and the surrounding area, which is a 3 by 3 millimeter. And we can see how much ischemia at the level of the superficial plexus and much more ischemia at the level of the deep plexus. How about knowing the difference between the cyst, as we see in the picture here? Probably this is a cystoid, and this is the real ischemia. We will combine this with the ONFAS. So combining this with the ONFAS means that we can see where the cyst is, though the cyst can press on the deep plexus and causing ischemia, and where the real ischemia is. So this can explain why the vision is markedly diminished, not because of the cystoid edema alone, but also because of the ischemia, which can be clearly delineated by superficial MDPs. And this is the density, and this is the flow. And we all know that blue means no flow, yellow less flow, and red is a very high flow. When I order OCTA, I had this patient, 65 years old female, coming to me with this fluorescein chart. She is very uncooperative, as the doctor did the fluorescein for her. She had media opacity, which is scatter, and she had this late phases because she had reaction at the beginning of the diet. So I can say that this is a proliferative with MVD and MVEs, but I cannot delineate how much ischemia in there. Repeating OCT is very beneficial, as you will see. It can penetrate through because I have the sweat source. So this, look at this, crystal clear where the ischemia is, where the new vascularization is, and where is the MVD. And also on the right side, you can see how much extensive ischemia in there, which was not clearly seen by the fluorescein because of the media opacity and the quality of the patient, of the photos, and how we can detect everything, NVEs, NVD, areas of ischemia, and we can start treating this patient based on this. Let me go to another case. This is an interesting case with OCT in I did OCT in a 65-year-old male with diabetic retinopathy. But looking at the picture, this is not only a diabetic retinopathy, we have a coincident lesion, which is age-related macular degeneration. Looking at the picture, we can see here microaneurysm, we can see microaneurysm, but there are some retinal pigment epithelial detachment, some drusen all over the posterior bone, and the patient is complaining of the right eye. Let's have a better picture for this. OCT, horizontal line scan showing nothing to be seen on the left eye, but look at the right eye. Typical cystoid macular edema. But is that quite good enough? Looking at the OCT, we have to always interpret or go deep. Look at the retinal pigment epithelium. We can see there is cystoid edema, and it is explained by the presence of diabetic macular edema due to leaking perifoveal capillaries. Let me show you other multiple line scans to fulfill your satisfaction. This is through the pigmented lesion over there, which is RP hyperplasia, which we can see sometimes in long-standing age-related. Another line scan through the retinal pigment epithelium tent, which we can see here. But again, keep looking at the outer retina. Look at the elevation of the retinal pigment epithelium. Look at the thick choroid. Look at this flat and irregular RP detachment, where the RP is separated from the Bruch's membrane, which we call the Doppler cell. So before starting treating this patient, we have clearly to identify, is it only one pathology or it's a combined pathology? We said it's an age-related macular degeneration, and it looks like a dry type. But how about the cyst? Is this cyst related only to diabetes, or this edema related to CMV? Look at the OCT angio. OCT angio, this is, as we said, the superficial plexus. This is the deep plexus, and we can see there is ischemia. It's definite ischemia in the perifoveal area, plus the cyst, which can be seen by the ONFAS. But where is the outer retinal layers? Here it comes. This is the 3 by 3 cube. And if you look, this is the fluorescein geography, by the way. Multiple RP detachment, leaking perifoveal capillaries, but there is some kind of hyperfluorescence inside the fovea itself, which may be related to the cystoid macular edema, but look at the outer retinal layers. It's a clear, there's a CNV down there under the flat and irregular RP detachment, and probably it is really also sharing in the formation of fluid. Preloading dose of anti-VEGF, this patient was treated by Eylea, and she get flat. Look at again, the RP detachment is still there, but the macula is getting to right. And this is how we can judge if this CNV is active or not. There is an activity, high flow, there is no flow, and it's a filamentous or long filament-like vessels, which mean that the membrane is not active. Sometimes we find lesions, we should not miss cases like this. Let's move to the RVO. We all know that sometimes we don't do fluorescein for RVO anymore, but sometimes we need to know if this patient having ischemia in the macular area. Look at this. This patient had a small cyst with perifoveal cystic changes, but the OCTA can clearly delineate that there is much more ischemia at the level of the deep plexus than the superficial plexus, and this explains why the vision is markedly impaired in this eye, though fluorescein doesn't show much of this ischemia, but OCTA is superior in this. And this is the density map. You can see the foveal avascular zone is enlarged, multiple areas of capillary dropout, or we call it low flow, and how much enlargement of the foveal avascular zone at the level of the deep plexus, not only the superficial plexus, and it always explains why the vision sometimes in RVO is markedly affected and we don't see corresponding pathology in the fluorescein angiogram. What else? A patient coming with what we call impending vein occlusion. Why we call it impending? Because there is no much macular edema. It's tortuous vessels, hemorrhages, disc edema, but there is nothing to explain why the vision is 6/60. We used to see impending. We say we follow up this patient. Sometimes the RVO is spontaneously resolved, and this is the natural course. But why the vision here is 6/60? The macula is dry. Foveal contour is there. So why the patient is not seeing well? Is it because of the congestion at the optic disc? I don't think so. Let's go to the multiple line scans, which will tell us why the patient is not seeing well. And it's clearly seen here, it's a PAM, which is a paramacular acute medial maculopathy, which is ischemia at the level of the deep plexus, not hitting the superficial plexus. There is no leakage from the superficial plexus, and this is only inside to the deep plexus, and you can see here at the level of the deep plexus, where we can see the amount of ischemia, and this is the on-pass, what we call it fern-like, which is the leaf, hyper-reflective leaf. You can see in the perifoveal and the parafoveal area the amount of patches of ischemia. So this is what we call paramacular acute medial maculopathy, which we see clearly sometimes in diabetics, in vein occlusion, and it can explain why the vision is diminished in these cases. So this is another important issue doing OCT angiography in these cases. And this is the paracentral area full of scattered ischemic patches. And this is the abbreviation of paracentral acute medial maculopathy, or PAM, which isolated deep capillary ischemia, not affecting the superficial, only the deep plexus, and reside at the inner and outer border zone of the inner nuclear layer, as we can see here. So we can see the hyperreflective lines at the level of this deep plexus, like hyperreflective bands delineating the amount of ischemia, and it affects the vision. And especially those patients come saying that we have a central scotoma. Are you following me, Dr. Mohammed? Hello?
We are following you.
Yes, we hear you.
We hear you, doctor.
Okay. Okay. I hope I'm not going so fast. Am I?
No, it's very good, very good.
Okay. Let's go to OCT angiography in CNV. We all know that there is a lot of debate saying that OCT angiography is not helpful in the periphery, but help in the macular area. And CNV happens in the macular area. So a lot of papers published about the identification of CNV by OCT angiography. OCTA give us information about the flow, as we can see here, how the membrane is active and has different patterns. It's not the time to explain that, but I will show you some pictures. No membrane is active, give us the criteria around the activity, and decision treatment can be also helpful by OCTA, especially in certain cases, which we will discuss in a minute. Also, it can be defined by the structural co-incident structural OCT, like the line scan, where the membrane is. Is it subretinal? Is it sub-RPE? Is it inside the retina? So this is a very valuable information by OCT. To know if the OCT, to know if the CMV is active or not, we have to look at the OCTA. There is increased density of these capillaries. There is anastomosis at the periphery and arborization of the membrane. All these are signs of activity, and this is the density map where the flow is very high in the main trunk and in the arborizing vessels. So these are all signs of activity, and they say looping. You can see multiple loops at the periphery connecting the peripheral vessels. They give an example of this as a blooming tree, a very fruitful tree with its leaves, the green leaves, which mean the trunk, and viable leaves, meaning that this membrane is active. How about inactive? After repeated injection, what the membrane will turn into? The membrane will not disappear because there must be a trunk there. There must be a source of the membrane, though sometimes OCTA doesn't show this. But we can see here that these are trunks, like dead tree. There is no leaves, there is no arborization, there is no anastomosis, and this is when we make sure that the membrane is not active anymore, and sometimes we need to follow up patient with the structural OCT and OCTA, as I will show you in a minute. Let me go when I do OCTA in cases of CMV. Not all of the cases, because fluorescein and OCT again is quite good enough. But let's go and discuss in a couple of slides what is the meaning of non-exudative wet AMD. We used to classify AMD into dry and wet, and the wet is the exudative because of the fluid. This is a third category called non-exudative wet AMD. Where do we find that? It is discovered accidentally sometimes in the other eye of patient with neovascular AMD, like the picture in here. This is the right eye of a patient with established CMV, with cystoid macular edema, elevated retinal pigment epithelium, which is type 1, where the membrane is under the retinal pigment epithelium, or we call it type 1 CMV. How about the left eye? When this patient presented to me, I looked at the left eye and said, this is a retinal pigment epithelium detachment with a few drusen scattered at the posterior pole. Yes. And this is the retinal pigment epithelium detachment proved by the OCT. What is the meaning of silent CMV? Is there a CMV down there? Yes. Why this CMV is not giving us any manifestation? There is no hemorrhage, there is no exudation, there is no fluid in here in the structural OCT. So the OCTA is showing a very active CMV under this flat and irregular RP detachment. How come this CMV is not giving us any manifestation on the structural OCT? A lot of theories, a lot of publications, a lot of talks in the literature about silent CMV. Should we start treating this patient, though there is no activity on the structural OCT or even on fluorescein? Should we close follow-up of this patient? Treating this patient will be depending on fluorescein, OCT, or OCTA. Results be done there, but it is not giving us any manifestation. 5 years ago or 4 years ago, I used to treat these patients. And this is the patient. I gave her once anti-vision, and nothing happened. The membrane is still the same. And I did in other couple of patients, and I found no change. The vision is still the same. There's no change on the OCT. There's no change on the fluorescein, and OCT is almost the same. So 3 years later, only follow-up of this patient showing that maybe the flat and irregular RP detachment is increasing, but the membrane is still the same. There is no changes on the surface of the retina. There is no structural changes, and the vision is still 6-12. So most of the literature now saying we should closely monitor this patient. Give you another example. A 74 years old female patient with dry AMD in both eyes. We can see the drusen, and we can see some RPE defect, mottling of the RP in both eyes in the perifoveal area. And when I did OCT, structural and OCTA, I found bilateral silent CMV, and the patient was not complaining except of the nuclear cataract with 6-12 vision. Should we treat this patient? I did follow up this patient because I had the experience, and I followed her for 2 years. She only dropped down 6/18 because of the cataract. But still, we have 2 silent CMV down there, and it is not affecting the vision. a lot of literature saying why we see this. They call it silent CMV, where the CMV is starting, or they call it different type, what we call non-exudative wet AMD. And some even of the doctors like Philip Rosenfield say it's a friendly CMV, which nourishes the retinal pigment epithelium, though I'm against this. I don't think there's anything friendly about CMV. But in my opinion, this is a very early stage of CMV, because patients with CMV only present it to us when they have complaint like visual loss, blurring of vision, metamorphopsia, but they never come without visual complaint. So it means that it could be a very early stage of CMV, and we will never know how long these patients will keep silent and when they will start leaking and give symptoms. And I have another lecture about that. But all I can tell you, this patient only discovered by OCTA, they need to be followed up closely by structural OCT and OCTA. You don't need to repeat fluorescein angiography. Any changes in the vision or metamorphopsia increasing, we have to do repeat OCT angiography and structural OCT to find out if there is a fluid, we start to inject. If there is not, we start to follow up. We keep following up. Let me go to another part of the lecture, OCTA in pediatric age group. We all know that doing fluorescein angiography is very difficult. ICG, it's impossible almost to keep the child 30 minutes on the machine, and structural OCT sometimes is not conclusive by its own. So this is a patient who was diagnosed already as Best disease, and he had recent diminution of vision in the right eye, and he could not do his activity at school. And his mother brought him in. He had Best disease, doctor, and we know that since 4 years, and we are following him up, and he was doing good at the school, but nowadays he cannot manage. And I looked at him, yes, it's a typical Best disease. And we can see the hyperreflective vision down there. And we all know that this is not a sensory detachment. This is exactly like an empty space elevating the retina. It could be previously light officine deposition and cleared up. It could be the action due to the failure of the pump of the RPE. But I did multiple line scans for both eyes, and I looked at him, why the patient is not seeing? And I looked at the boy and I examined him clearly, and I said, this boy had, as I said, diminution of vision in both eyes. But when I looked at him and I examined him, I found intermittent exotropia in the left eye, which means that this eye was not the main or the dominant eye. The right eye was the dominant eye. So I looked again and I did multiple line scans on the right eye, nothing to do with it. There is no sign of anything to explain why the boy is complaining. Until I did OCTA, and this was 2016, 4 years ago now, and I found a CMV down there. Again, is this a silent CMV? I don't think it's a silent, it's a CMV. But why it is not showing any changes in the retina? Because silent CMV is completely different from age-related and myopic CMV. We don't see exudation, we don't see hemorrhage. In the complicated retinal dystrophies, manifestation is completely different. It could be a silent, as I said, but I don't think it's a silent, it's an active CMV, and the manifestation is not the typical as we see in old age. So this is the fluorescein and OCT, the color and fluorescein, and I looked back again. How did I miss the CMV? Look at this. The circle is surrounding the vitelliform lesion, but this is not actually a vitelliform lesion. It's the CMV inside the vitelliform lesion, surrounded by tiny hemorrhage, which I missed during interpretation. So it means there is another signs we have to look carefully, because we look at the best hyperreflective material, yellowish spots, patient is complaining, but they always complain because of the lesion encroaching on the focal area. But this is a typical CMV. How can we anticipate that? Complaint of the patient, looking carefully at the fluorescein OCT, and I did inject that boy anti-VEGF. And again, I repeated the OCT, the structure, there is nothing there. You cannot tell from the structure OCT if the membrane is improving or not. And this is the multiple line scans, but look at this. This is the OCT. You can see the flow is getting less and the membrane is getting smaller, and we can stop injecting this boy at this level. And fortunately, we regain vision 6ET. So he can read now, he can work at school, and I depended only on OCTA for the diagnosis. What else you should use OCTA? In cases of chronic CSC, where everything is destroyed. We call it sick RPE syndrome or diffuse pigment epitheliopathy, multiple points of leak. The patient has a chronic CSR years ago and suffering from diminution of vision every now and then. When we look at this, we will never be able to tell if this patient is harboring CMV or not, except if we do an OCTA like this. Because looking at the structure, OCT, we can see, again, flat irregular RP attachment with enlarged undilated large choroidal vessel, pushing the choroid capillaries, elevating the retinal pigment. But we will never thought that this patient might harbor choroidal vascular membrane, and probably these are polypoidal choroidal lesions in these cases. And this is the polyps at the end of the arborization. So sometimes when you face with a CSC with recent diminution of vision and you look at the fundus and you say, we cannot tell if the fluid is the cause or not, do OCTA, because some of these patients might benefit from intravitreal injection of anti-VEGF to regain the vision. Another thing, if you have a patient coming complaining of blunt trauma like this, and he is 28 years old male, and he had left recent diminution of vision following blunt ocular trauma, and he's accusing the guy who gave him the trauma that he lost his vision because of that. And I looked at him, I said, there is hemorrhage, there is elevation of the macula, and I can see that there is mottling of the retinal pigment epithelium, and I can see something leaking under this, which is expected to be a CMV. But with a trauma in a 48 hours doing a CMV like this, we all know trauma can cause choroidal rupture and then complicated by CMV, but this doesn't happen in 48 hours. So I did OCT and I found, yes, OCT and OCT prove that this patient had a CMV. Again, it's a CMV, but it is against the logic. Why CMV developed in a case like this? Look at this clearly and always remember to check the other eye, because the clue might be in the other eye. When I looked at him, I said, what is this yellowish coloration? I thought it's because of the trauma, commotion, and it can be commotion. And here's the CMV, and here's the OCTA proof that we have a nice CMV down there with arborization and extension. But when I looked at and here's again the structural line scan, we can see the flow inside the CMV. But when I looked at the right eye, what is this? Again, there is mottling of the pigment epithelium. And I asked the patient, did you have a trauma in this eye? He said, no, only the left eye. So the patient was a malingerer, he was a liar. And I looked at him and I did OCT and the clue is there. It is empty fovea, disrupted outer retinal layers, parpopial degenerative cyst, and OCTA was the clue. We have at the level of superficial plexus nothing, but at the level of the deep plexus telangiectasia, which is the cause of this RP mottling. And you can see here the perifoveal telangiectasia, which is complicated by CMV, not probably related to the trauma. And the patient was accusing the guy who hit him. And getting more and more details from the patient, he said, yes, my vision is deteriorating since almost 1.5 months in this eye. So again, we could save the hitter by doing OCTA. Sometimes we do OCTA to exclude, not to prove that there is a CMV. This patient was referred to me for injection. He had a CMV in the right eye, multiple leaking sources of leaking points of undetermined source in the right eye. And this patient has 61 years old, and he was diagnosed as age-related macular degeneration wet type, and he had a posterior subcapsular cataract in the right eye. Intraocular pressure was normal, and the diagnosis was CMV, and this is his fluorescein. I scanned it, and I have it with me, and I looked at the color, multicolor, and the fluorescein, and there is something leaking down there, which starts here, and then it increased intensity and a little bit in size in the late phases of the angiogram. And I looked at him, and I said, should I start injecting him? No. Let me look at his OCT. And I did OCT, and I found this. And this can be easily mistaken for CMV because it's a subretinal material with thickening, minimal thickening in the center of the macula. So it could be a CMV. But in the differential diagnosis, and I can listen to you, a lot of you saying now, it's a Best disease. Yes. So I did fundus autofluorescence, and yes, it's a Best disease. But again, can you exclude CMV? It could be an early CMV down there. So I did OCTA, and I found nothing at the level of the outer retina or the choroid capillaris, which can exclude CMV and saying this patient doesn't have a CMV. So again, I did OCTA to tell the patient that you don't have, because the patient, telling you the truth, he was already injected twice in this eye, and the doctor wanted to continue, and the patient said, I'm not improving. The patient went back again to another doctor, and we kept injecting him, and he put aside the OCTA. This was 4 years ago, and he kept injecting him until he developed a macular hole. Epiretinal membrane with attraction for the repeated injection, and he developed a macular hole. So we shouldn't inject patients for vein. Nothing can regain the vision here, and we have to diagnose CMV properly before start treating the patient, because there is a medico-legal problem in these cases. In high myopia, we all know that it's very difficult sometimes to say if this myopic patient has a CMV or not, because again, the myopic CMV sometimes comes with a minimal fluid or minimal changes at the level of the outer retina. This is the left eye of a female patient with a CMV in the left eye, long-standing CMV, and fluorescein angiography of the right eye showing a small, tiny lesion in the center of the forehead. And the patient is complaining of central scotoma, not metamorphosis. When I looked at him, is that a typical CMV? I did OCT, and it was not conclusive, because we all know it could be a scar, it could be an old one, multiple line scans, and minimal fluid. I cannot say there's much fluid in there, but look at the OCTA, it's conclusive. It is a CMV. And we should start treating this patient based on this. Here's the CMV with a high flow. It's not typical like arborization of this, because we have different pattern of high myopia, and we can see the flow inside the CMV. Another patient coming with a foveal hemorrhage, and she's a female, 27 years old. She's a doctor, a resident in our hospital, and she's complaining of left diminution of vision with paracentral scotoma, high myopia, -8, 20/60 vision, and we can see here the hemorrhage here and elevation due to the hemorrhage. Should I start treating this patient? I did OCTA, and I found that the CMV is in different situation. It is not below the hemorrhage, it's at the edge of the hemorrhage where the CMV is there. Very tiny CMV, starting CMV, and we started to treat this patient. After treatment, the CMV is getting less and less, and only 2 injections of Avastin, she regained 6/12 vision. Let me give you couple of cases. I still have time, I know. Couple of cases, and I will stop and let you think, and then we can answer the question to them. Sometimes OCTA can be the only clue for diagnosis of this patient. Here's a male patient, aged 55 years old. He's hypertensive, under control. He has bright, recent glaring vision, 1 month period, and his visual acuity is 6/24. Fluorescein angiography, I see nothing. Everything is intact. The disc is fine. The vessels is filled, and the arteriovenous timer is fine, and the vision in the left eye is 6/6. Why the patient is complaining? This is the left eye, by the way. Let me give you a bigger picture. Here's the patient, and I did OCT, and I looked at it. Look at this. And tell me, what do you see in this OCT? I'm pointing to some hyperreflective area in there. Another line scan, you can see a hyperreflective band at the level of the deep plexus, which means this patient had insult at the level of the deep plexus. What kind of insult? He doesn't have diabetes, he doesn't have, he's controlled hypertension. Why he's showing this? Another line scan, multiple areas of infarct at the level of the deep plexus. Let me give you another line scan. All the line scans showing this. So it means that he had infarcts all over the perifoveal area. And I'm magnifying the color fungus. What do you see in this color fungus? Look at this. What are these? Yellow spots. These are showers. This patient had a carotid atheroma with calcification, and these are showers from the carotid. So it means that this small emboli left the superficial plexus and went deep to occlude the perifoveal or the parafoveal deep capillary plexus, and this is the cause of diminution of vision. It's a long-standing, and he already had showers before, and he told me that he had some kind of brain stroke, but he not had any residual manifestation. And when I did the carotid, I was astonished that he had a large atheroma with calcification. So instead of doing further and further investigation, or telling the patient we don't trust your complaint, you can find out why this patient is suffering. And this is the OCTA. Look at the OCTA. We don't see exactly what we see by the acute phase of pain or paramacular acute nodule maculopathy, but we can see this is at the level of the superficial plexus, which is intact, but look at the level of the deep plexus. Enlarged phase, which means that most of the insult is at the level of the deep plexus, and this is why the patient is complaining of scotoma. Central scotoma, and he's not happy with his vision because he already had infarction at the level of the deep plexus, and it's a long-standing and ongoing process. Here's another case, the one before the last one, the male patient, 40 years old. I'm giving you the fluorescein. What do you see in the fluorescein here? Let me help you out. You can see areas of capillary dropout here. Probably these are infarcts. And this patient had a recent attack of hypertension, shooting of blood pressure, and 180 over 120. He's not diabetic. He had some kind of renal function impairment, and he's complaining of marked diminution of vision with a visual active 660 and the left eye was 6.9. Let me show you the color from this picture. What do you expect in the color from this picture? Soft exudates, yes. He had multiple soft exudates in the peripapillary area. But nothing is seen in the central area but fluorescein. Why we are not seeing anything? Because the superficial plexus again is intact, and we cannot delineate what is going on in the central area except if we do multiple line scans again. So this is infarction again at the level of the deep plexus, and there is infarction at the level of superficial plexus, which is the soft exudates or the micro occlusion of the lateral nerve fiber layer capillaries. This is another oblique line scan showing the hyperreflective bands in here. And this is an oblique line scan passing through one of the superficial infarcts or the soft exudates and passing through one of the deep infarcts, which is the infarction at the level of the deep plexus. So this is a combined microinfarction at the level of superficial and deep plexus. And his 3 by 3 millimeter cube, look at this. Superficial plexus, yes, there is kind of ischemia, enlargement of the phase, but most of the insult is at the level of the deep plexus. Most of the infarction is at the level of the deep plexus in the perifoveal area, and this is the cause of diminution of vision. We never thought about this when we had only fluorescein angiography and OCT, and the old OCT, which was not high resolution, we could not get all these changes. But nowadays, this is another bigger picture, millimeter, and you can see here, superficial plexus is fine except of this area, but the deep plexus is markedly insulted with multiple areas of infarction, and the AMFAS can see the whitish patches, which means marked perifoveal capillary occlusion at the level of the deep plexus. And let me give you a wider field showing the superficial and the deep insult. The superficial insult obstructing the flow or not hiding the flow inside the superficial plexus, but this is not seen here. This is the deep plexus, and we can see how much ischemia or insult at the level of the deep plexus compared with the superficial plexus. And this is another explanation that this patient had marked drop of vision, and we have to put this in consideration when we have patients with a shooting blood pressure or malignant hypertension complaining, and we don't see anything related in fluorescein angiography or structural OCT. We have to look at the OCTA to find out what's going on. And this patient had a renal retinopathy, and he's under treatment. My last case, this is a female patient. She's a doctor, and I used to see her 16 years ago when she was young, and she had Best disease. I know, and I've seen her since she was almost 16 or 17 years old. She had right recent blurring of vision, and her left eye had old macular scar, as we see, and visual active 0.8 in the right eye, which is not bad, and 560 in the left eye, an eccentric fixation. Why I'm saying she's having a scar in the left eye? Because this is the picture in 2003, 17 years ago. She had developed a CNV on top of Best disease, and I didn't do anything for her until she. Why didn't I do anything for her? Why didn't I inject her? Remember this? 2003. There was no intravitreal injection at that time. So we used to follow up this patient till the natural history happens and they lose their vision. And that's why she's coming quickly with the right eye. She said, I'm not happy, I'm not seeing well. And I respected her complaint and I did OCT. I could find nothing. And I told her, I don't see anything. It's 0.8 vision, she's 6'9" almost, and nothing in the structure OCT or the fluorescein explaining why. And I can see there is a staining of the vitelliform lesion and nothing in the structure OCT. So she said, I'm not happy. I'm not satisfied with this vision because I used to see better. And I returned to her file. She missed follow-up for 5 years, but the last 5 years ago, she had 0.8, the same vision, but the quality is not that good. I did OCT, and I looked at this. I said, is that a silent CNV? Or this is an early thing? I didn't know. But it looks like something is in there, inside the vitelliform lesion. So I couldn't explain why she had blurring vision, though there's no fluid, there is nothing in there. And I told her, doctor, please give me a couple of weeks and pass by again. She said, I'm not happy with the vision. I said, I cannot start treating anything right now. But I have in mind that this could be a silent CNV, it could be an early, very early stage, because it's like a small active fibrovascular from inside the CNV. And this is a very early catch in this eye. 2 weeks later, not 3 weeks, 2 weeks later, she came in with typical manifestation of CNV, fluid, elevation, and diffuse macular edema. And look at this, the membrane is getting huge in a couple of weeks only. Vision dropped down to 0.6, and she said, didn't I tell you, I'm not getting better, I'm getting worse. And I repeated that, and I told her, now I can start treating, because this is an active CNV. And she said, would my vision be back? I said, I don't know, but I injected her, and this is after repeated IV injection, and look at this. It's crystal clear that the fluid is gone. The patient regained 6 vision, not even 0.8. 6 vision. I don't know how, but she was happy, she was satisfied, and she told me all the blurring symptoms is gone. So sometimes we have to catch this patient in a very early stage. And I told you, sometimes this patient do not manifest with the typical picture of CNV. They don't get hemorrhage much, they don't get exudation much. Only they start to have metamorphosia or blurring of vision, because minimal fluid sometimes can affect the visual active, especially if the patient is intelligent as this doctor. So this is pre and post injection, and I was glad that the patient regained 6 vision. I'm still following her up for 6 months now. There is no recurrence after now, and she is coming every couple of months, not 1 month after that. So it's a very good point to catch a patient at an early stage and to prove it by OCTA. So my take-home message is OCTA is becoming an important tool in real-life practice, as we have seen in many cases I presented, and it's crucial in many retinal vascular disorders when fluorescein angiography and OCT are not conclusive, as we have seen, especially in children. And it's the only capable imaging modality of revealing quiescent or silent or non-exudative CNV. We have to suspect these patients in the other eye of CNV, or sometimes they come out of the blue sky without anything except flat and irregular RP detachment. In any case like this, we should do OCTA, and can be the only clue in cases of macular dystrophy complicated by CNV, and the best method of follow-up of this patient after repeated intravitreal injection, not only structural OCT, we have to combine structural OCT with OCTA to make sure that the membrane is gone, because structural OCT sometimes is deceiving you and not telling you the whole story. And OCTA can also exclude CNV in certain conditions instead of injecting the patient of best or other form vitelliform for vein and getting complications from repeated injection, so we can avoid that. And thank you so much for your listening.
Thank you very much.
Thank you very much, Dr. Majdi,
for this nice presentation.
Thank you. I hope I'm on time. I think I'm on time, right?
Thank you, Dr. Magdi.
We are more than happy because we are so enjoying with your presentation.
Thank you. Thank you.
Dr. Fawaz want to talk with you, sir?
Okay. Good evening, Dr. Majdi, and thank you again for your.
كيفك فواز؟ خلينا نحكي عربي. كيفك فواز؟
والله احنا اول شيء احنا ما التقينا بعمان ريتنا ميتنج، بس اكيد الفرصه سعيده انه نلتقي بك مره ثانيه.
انا كمان سعيد بك جدا، بس
محاضراتك رائعه.
let's turn back to English.
Okay, thank you very much for your wonderful presentation. And again, you highlight in your presentation the importance of OCTA in assessing the diabetic macular edema, especially the ischemic element. And this is very important if you want to predict the vision of our patients if we start to initiate the anti-VEGF treatment. And also in wet AMD, especially in cases of subretinal hyperreflective material, because sometimes we need to know whether these subretinal hyperreflective material are just a vitelliform lesion or as active CNV. And as you show to us in the flat or shallow RPE detachment, because sometimes these shallow RPE detachments may hide silent CNV. And as I remembered 4 years ago when we gave the presentation about the OCTA, I think you and also me, we were treat those cases, but now the silent CNV, there's no need for treatment because they need a long time to develop an active CNV. And when you treat them, you may induce a geographic atrophy. Just rapidly, my question to you, which type of scan you prefer when you use the OCT angio? Is it 3x3, 4x4? And when you need to follow up the patient, you should use the same scan or a different scan? Thank you very much.
Thank you, Fawaz, for the asking, and thank you for the compliment. I always use 3x3 because it's highest resolution, especially in the macular area. Sometimes I go to 4x4 or 6x6 if I find the lesion I cannot get by 3x3, though 3x3 is almost quite good enough, especially in CMV cases and PAM and all these cases. But sometimes you need a bigger view if you are detecting, like the patient with the PAM, I needed to see if the insult is only in the parafoveal area. No, it's extending up to the disc. So again, I use 3x3. I always do multiple line scans. You shouldn't count on only one line scan. As you said, multiple line scan is very important because sometimes you can miss the PAM by doing only vertical, only horizontal, and the insult is not in this line. So multiple line scans is very important. 3x3 to start with, and you can enlarge that. And I always start by 3x3 because you all know, you know that because you have the machine, you know that the 3x3 is the best. In all machines, you should start by the highest resolution to get the fine details in the macular area.
Okay, thank you very much.
Thank you for the question.
We can take a question, Dr. Magdi, please. We have a question from Dr. Mohsen Iqbal again.
Yes.
Mohsen.
Assalamu alaikum. Very
Alaikum
nice
assalam.
Professor. Excellent. We have seen very much deep insight view of the OCT angiography. I wanted to ask that how can we distinguish between active CNV and silent CNV in OCT angiography?
That's a very good one. Active or silent? As I said, this is a contradictory. When I said it's inactive, I said there's a long filament with no arborization, no anastomosis. Sometimes you look at this and you find it the same way, and we can still say it's a non-exudative. Why? Once you found any neovascular front at the level of the outer retina or the choroid capillaris, it's a CNV. Because this area, we all know it's devoid of vessels. So once we find this, it's a CNV. So if you have no manifestation in the overlying retina by structural OCT, like fluid, like exudation, like edema, like cyst, it's a silent CNV. It's a CNV down there, but there is no exudation in the retina. So it's a silent CNV. And as I said, sometimes there is a very small line in between. You find early fluid. Is this because the CNV is getting active or not? This is why I depend on both structural and OCTA. Structure will show you minimal fluid, but OCTA sometimes would show that the membrane is progressing and the flow is getting higher and increasing in size. OCTA, and it's not reflecting what's on the structures. So it's easier to catch the progression of this silent CNV by OCTA better than the structures.
Dr. Magdi.
What about follow-ups? When should we follow up?
Yes, both of them, structural and OCTA. You should never repeat the structural alone. Because sometimes I have a complete lecture on this, and I was going to give this in Amman, when Dr. Fawaz mentioned about silent CNV, what you need to know about. So sometimes you do the structure, you find no fluid. But you look at the OCTA, the size is increasing, the flow is increasing. In a couple of weeks, you will find the manifestation in the structural OCT with fluid and hemorrhage sometimes. So once we detect progression of this silent CNV, we will start treating, and don't forget the vision. These patients are always intelligent because they lost most of these patients the other eye. So once they have blurring of vision, quality is getting down, no much fluid to explain that, and OCTA is showing the progression, we should start treating these patients.
Dr. Magdi, may I ask a question, please?
Yes, Muhammad Habib.
My question is about if you have a CNV already, we are treating them. You depend on structural OCT or in OCT angiography on follow-up of this patient. Specifying the question, if you have in structural OCT no subretinal fluid, and we found the membrane, but there is no subretinal fluid or intraretinal fluid, and we have an OCTA, and the OCTA have a clue of activity. You re-inject this patient or keeping follow-up of this patient until the structural OCT regain collecting the fluid, either subretinal or intraretinal.
That's a tricky and hard question. Okay, we always depend on OCT in treating CNV, right? Because we have to find signs of activity on OCT, structural OCT.
Yes.
We have to have fluids, and we have to differentiate between subretinal fluid, intraretinal fluid, and sub-RP fluid. So again, the standard is the structural OCT.
Yes.
If we have residual intraretinal fluid, we should keep treating. Even on OCTA, there is complete regression. But I don't think if you do a very good OCTA, you will find a complete regression. You will find the flow in the OCTA. But again, depends, and this is a message for all of us, depend on the structural OCT because this is the only solid imaging modality we have, and we know about it everything. We know about all the changes. So make sure that the intraretinal fluid is gone. Subretinal fluid is an issue because sometimes we can leave subretinal fluid because of the fluid study. But again, the regaining of the foveal contour, the maximum visual we can get like 612 in the last couple of injections, and the patient is not improving. Minimal subretinal fluid can be left there, but intraretinal fluid we should not. Sub-RP fluid we are not aiming to try it. So always depend on the structural OCT, and don't go to the luxury of OCTA because it will be costly for the patient. Sometimes it's artifact, sometimes it's not giving you the whole picture. So structural OCT is the main thing.
As you know, Dr. Magdi, as you know, in diabetic patient, when we inject the patient, we follow up the visual acuity and the structural OCT. Do you agree with me that in CNV, whatever, if there is no gain in visual acuity, we inject once there is activity?
It depends on your regimen. Let's go back again. This is a very good question. It depends on your regimen. If you are treating treat and extend, this is an issue. If you are treating PRN, this is another issue. For instance, if you are treating treat and extend, and after the 3 loading dose, you get dry macula, vision is 6.6. Let's say maximum vision.
Yes.
6.6, dry macula, and the patient is dry after 3 injections. If you are treating treat and extend, you should inject and extend to 6 weeks. If the patient comes back in 6 weeks, 6.6 vision, dry macula, you will inject and come in 12 weeks. So this is the regimen. But if you are depending on PRN, after the 3rd injection, there is no fluid, everything is dry, maximum visual gain, you should stop injection and do OCT after 1 month. So
perfect.
In my opinion, I used to do PRN, but nowadays, treat and extend, I think, is the best. Because if you waited for the patient to come with fluid, sometimes they come very aggressively with many.
I agree with you. I do a treat and extend in CNV and PRN in diabetic macular edema.
That's it. That's the best regimen.
Yes. Thank you, Dr. Magdi.
Thank you.
Dr. Majdi, how are you? Can you hear me?
Yes, I can hear you. Who are you?
Dr. Amin.
Dr. Amin Mara. Dr. Amin Mara.
How are you, Dr. Amin? We haven't met in person, but I've seen a lot of your presentations on the net, and I wish we had met in Abu Dhabi and in Dubai a couple of months ago, but unfortunately we couldn't make it.
Due to visa issue, but my question here, the internet was cutting off while you were talking about OCT angiography for cotton wool spots. I didn't hear you well. Is the infraction on the level of the capillary plexus or in the superficial capillary plexus?
The cotton wool spots is the superficial plexus, definitely.
Oh, okay. Because due to the bad connection, I heard that the infraction on the deep capillary plexus. That's why I
no, it's the superficial plexus, and sometimes it's combined with the deep plexus, which we don't see.
Again about that.
Dr. Amr Mahfouz.
Okay, thank you very much. That's mean that was a problem with connection.
Tofi, we are behind the time.
Okay,
Still
if you have a stop, خلاص, okay.
Dr. Magdi, may we ask you to stay with us for the next session? We have a very quick session. We need you.
I'm staying. It's the longest period I've stayed on my chair. Okay, I'm staying. I'm with you. Thank you very much for the invitation. Thank you for the audience. I can see hundreds of them still there, and I'm sure that the panel discussion will be very fruitful. I'm interested to hear the other colleagues' opinion. Thank you. Thank you again.
Thank you very much. Thank you very much, Dr. Magdi, for your participation and for your very informative lectures. Now I would like to ask our panelists to join us for the retina sessions. But before that, I want, we are in an era of COVID-19. While we're preparing for this session now, I just want you to listen to this very nice music. It's done by Dr. Omar Ahmed Abdurrahman. I really like it, and I want you to listen for it just for 1 minute, just to refresh me. Thank you very much for Omar. I like it. I hope you like it also. Now let's go back again.
Thank you very much, Muhammad. Thank you very much. You hear me?
Yes, I can hear you, sir.
Yes, thank you. Omar is so happy with the presentation that you have presented his music. Thank you. But Omar is not a doctor. Omar is a sound engineer and he's playing violin. So that, and I think for every music he's going to produce, I will send this to you immediately. Thank you very much.
Thank you. Thank you very much, sir. Okay, now our panelists, Dr. Amin, Dr. Farid, please unmute yourself, and Dr. Magdi with us, Dr. Muhammad Tawfiq. Okay, Mustafa, you are with me, Mustafa?
Okay, Muhammad, with you.
Okay, so we will start. You can see the screen now, right?
Yes.
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 Yes, it's clear.
Just want to. Just a minute. Okay. So I'm sorry because we have so long time in this meeting. I hope it will be informative for all of us. Now we will start quickly a panel session about retina. We will discuss a very important topic today, which is the management of chronic persistent diabetic macular edema. Actually, it's a new term. I just know about it within the last few months about. And let's go through this case presentation. Okay, so it's 62 years old man. He is a diabetic for a long time. HbA1c is 9.3. Presented right eye 624, that was 20, and the left eye was 618, and the IOP was 19. So it's from this picture, you can see there is another product of diabetic retinopathy with diffuse macular edema. OCT, structural OCT are done for him. This is for the right eye, as you showed. We have the central focal thickness of 597, and the left eye is about 609. So we have from the structure BSB scan, diffuse macular edema with some exudate presented here. So I decide to go for a monthly injection of Avastin, and we start. This is the baseline injection, okay, and I inject him on a monthly basis after 3 months. This is the way we go for the right eye. This was 597, then go for 572 after 6 months, and for the right eye was 526. However, on the left eye it was 609, then become 522, then become 434. Now the 6 month was gone. This is what I have now. This patient have from 624 after 6 months of monthly injection of Avastin. He gave just 618. The IOB is 23. However, on the left eye it was 618, and now he gave 612 with improvement in the central foveal thickness. This is the baseline, and this is after 5 months. So I just want to differentiate and just not what is meaning by persistent diabetic macular edema, or this is a chronic persistent diabetic macular edema. Can you, Mustafa, tell us?
Okay, I'm with you. Thank you very much, Miss. I think it is very common scenario, very common in our practice. We see patient with the diffuse diabetic macular edema, and we decide to inject anti-VEGF. And after injection, there is no response or mild response. We don't reach the point of dry macula. You know, we can't reach the point of dry macula. I face this cases commonly in my practice. So this is a very common scenario and good case for discussion. In this case, when we preparing for lecture, actually I review many papers and I surprising there is many texts and many informations about this lecture. One of the information mentioned in the post hoc analysis of protocol I, there's a two definition. In the post hoc analysis of protocol I found two definitions: the definition of persistent diabetic macular edema and the other definition of chronic persistent diabetic macular edema. So in this case, the response, if we have a response and we reach the macular thickness less than 250, we reach to the dry macula, okay? After 24 weeks, this is normal. This is a good. If we don't reach the 250, we have still a macular edema, but we have a response, but still there is a macular edema, okay? But not reach 250 micrometer in the central macular thickness. This is persistent macular edema. So what is the difference between persistent macular edema and chronic persistent macular edema? Chronic persistent macular edema, Mohammed, is we have a response 10% from the baseline thickness of chronic macular thickness, okay? So if we have response of 10% of the baseline thickness, there's a reduction in central macular thickness by 10%, or we have a case of chronic persistent macular edema, but we don't reach the dry macula, okay? If we have a response more than 10%, okay, now we can call this case, it is a case of persistent macular edema. So we can go back to our case. The right eye, we can call the right eye persistent chronic persistent macular edema. As we see, after 24 weeks, the central macular thickness is not decreased by 10%. So in the right eye, there is a chronic persistent macular edema. In the left eye, there is a response. The macular edema in the baseline, 600. And then we reach to the 400. So it is a response more than 10%. There is a reduction more than 10% in the central macular thickness. So we have response. okay, but not reach the dry macula. This is called, by definition, this is called persistent macular edema. These two definitions mentioned in the post hoc analysis of protocol I. Okay, Mohammed, with you?
Yes,
okay, with me, Mohammed? Okay?
Yes.
Okay.
So now in your practice, Mustafa, do you switch after 3 injection or 5 injection? Let's put a pool.
Actually, this is dependent on the patient. If it is compliments and it is nagging the patient, I will shift for the injection. But actually, the guideline and the post hoc analysis, according to post hoc analysis of protocol I and post hoc analysis of protocol B, the shift should be after 24 weeks. After 24 weeks, if we have no reduction by 2%, so we can think for switch to the other anti-VEGF or switch to the steroid. What is the opinion of audience?
ممكن can I add a comment?
May I give the suggestion, please?
Yes.
Yes.
Yeah. Can I speak? Yeah.
Yes.
Okay. In my opinion, to start the switching, the treatment, for me, usually I start with the loading dose. After the 3 loading doses, I assess the response of my patient. If the patient didn't get any improvement in vision, for example, the improvement is less than 5 letters, the morphology of the edema is not improved, and at this point, I suggest to switch to another kind of anti-VEGF. Most of our patients, and I'm working in the private sector, they will not waiting 5 or even 6 injections in order to be shifted. So usually when I start, let's say with a high end of anti-VEGF like aflibercept, after 3 loading doses, if I didn't find a very good response, I will immediately thinking to shift to another arm of treatment, like the intravitreal steroid implants. But if I started with another kind of anti-VEGF, like for example Avastin or the ranibizumab, and after 3 loading doses I didn't get a very good response, I may think to shift to another kind of anti-VEGF, like the aflibercept. I will give a couple of injections, and then I wait and see the response. And there's many studies talking about even when you shift your patients to the steroid arm very early, you may get a very good visual outcome, because long-standing edema, more effect on the photoreceptors, more pressure on the photoreceptors, and this will be not good on the final visual outcome. Thank you very much.
Yeah,
Thank you very much, doctor. I agree with you. This is according to the patient. Yes, as I said, it is dependent on and also dependent on the response. Okay.
ممكن I add a comment?
I want to give a comment. Just we want to simplify to the audience what we mean by non-responding diabetic macular edema, because you know that most of the audience now are not all of them a retina consultant. So just we need to give in this session a guidelines when we consider the diabetic macular edema. It's a non-responding diabetic macular edema, and when we need to shift or to switch to another kind of anti-VEGF or to the steroid, because we need to reach to the general agreement between us. Thank you very much.
Okay, thank you very much, doctor. And if there is after 24 weeks, if there is no reduction in the baseline OCT and the central macular thickness baseline OCT, if there is no reduction by 10%, this is not response.
Do you think that the thickness? Do you think that the thickness is the important parameter, or the morphology of the edema?
Yes, it is very important. Central macular thickness and morphology, and also the visual of the patient.
But for me,
both hoc analysis of a protocol I dependent on the vision of the patient, on visual of the patient, and the both hoc analysis of a protocol T. For determining the response and the persistent macular edema depend on thickness, on the central macular thickness. Okay.
Please, can we
any comment from the minister?
No, I want to go to Dr. Magdi. Dr. Magdi, what's your opinion and the definition?
Fawaz raised a very good question. We have to define who is responders and who are not responders.
Yes.
So I don't know if 24 weeks, which means 6 months, is a long time to judge. As Dr. Fawaz said, after 3 loading doses, you have to look at the OCT, thickness and structural OCT. Because you can get amazed sometimes. The vision will not improve, or the vision is improved relatively to the central focal. So responder or non-responder has to be by central macular thickness. Non-responder, 10% or less is non-responder.
Okay.
More than 10%, they are responder. And there is another category, good responder or moderate responder. This has to be put in mind. This is the real life practice.
Dr. Magdi, can we add a comment, please, Dr. Magdi? If you have starting with 3 loading doses and you judge between the first scan of OCT before the first injection and rely on the third scan of OCT after 4 weeks of the third injection, and you didn't find any improvement in structural or visual acuity of the patient between the first OCT before the first injection. So in my practice, I'm doing OCT and visual acuity assessment before the first injection and the second injection and the third injection to justify if this patient is resistant to this type of injection or not. Because I have a patient that I'm comparing from first scan OCT before the first injection and comparing the second OCT but after 4 weeks of the third injection, there is no improvement at all. But in between, you have an improvement in visual acuity and you have improvement in the structural OCT. So my message is don't do as just 2 OCT before the first scan, first injection and the third injection. You agree with me or not?
Let me tell you something. You did OCT at baseline, OCT at 1 month,
Yes.
OCT at 2 months, OCT at 3 months.
Yes.
Am I right?
Yes.
You find mild improvement in the second,
And
right?
third,
in the first, after first.
After the first.
Mild improvement in the second. And in the third,
we have
based on
in
you are doing
the third,
fasting.
we have the same OCT of the first.
So this is non-responders. Why? You said it's improvement. In my practice, I've never seen a patient who improved much after first injection, second injection, and then he recurred after the third injection. They improve mildly, but not that dramatically. If you have improvement from the first and second injection, I don't think the third injection will be the same as the first. The third OCT will be the first as the first one.
Okay.
Unless this patient went into a disaster like hemoglobin A1C shooting, hypertensive retinopathy, renal failure, sometimes they recur very rapidly. But if you are going by the book, 1, twice, and 3 times injection, I don't think we should do. I used to do that because I have the OCT and I do it every month.
Yeah.
But in my observation, the patient who respond early, they keep responding. They don't respond at all. They don't respond.
Okay.
Sometimes I found it at the third month much more than the beginning. Sometimes I find that the thickness was 500, it came to 540 after the third injection. These are definitely a non-responder to this antigen.
Okay.
Okay. Thank you very much, Dr.
Can I add a comment?
Okay. Okay.
Okay. For me, if I have persistent diabetic macular edema, I will switch after 4 injections. There is always room for late response. I have seen those patients a lot in my practice. And they don't respond at the beginning, and then they respond later on, especially for those we don't have options to inject steroids. So my goal for residents or for a general practitioner ophthalmology that they can start always with Avast, this very cheap anti-VEGF. They can inject for 4 injections, then if the OCT didn't show didn't resolve the edema or suboptimum results, they can switch to aflibercept. I just want to add something here. I don't know why not all the people in the world are using Zaltrap. Zaltrap is the same as Eylea, identical, not similar, identical aflibercept protein, but a different upper solution. it is extremely safe. I've been injecting more than 5,000 or 6,000 injections by now. I don't have a single problem. So it is very cheap. It's the same price of Avastin. And I do another 2 injections. If the patient did not respond, then I switch to steroids. Another go, Dr. Mohammed, when you presented this case, those type of edemas that shows that cystic pattern with or without subretinal fluid, they respond very well to steroids. But there is, we have a problem that we don't know if this patient will respond to anti-VEGF or steroids until we try the anti-VEGF, we fail, we go to steroids. Because when edema responds to steroids, that means the main pathological factor is inflammatory symptoms, not VEGF itself. So I usually go with those types of edemas, intraepithelial, with suprachoroidal triamcinolone, as the first injection. I do it only every 2 months, starting injection number 0. Within 1 week to 2 weeks, I have a resolved edema. It works like magic. But as I mentioned, with cystoid macular edema pattern, those with macular thickening and those without cystoid macular pattern, they usually do not respond very well to this treatment, and I have to inject them monthly injection of anti-VEGF. And I just want to add a comment why it's 24 weeks. Why they in the literature it said like that? Because for commercial purposes to promote intravitreal injections, maybe. But as we all know that the microaneurysms have life is about 6 months. So if we do a fluorescein angiography for a patient with diabetic macular edema, we see leaking microaneurysms, and we repeat it within 6 months. We can see those microaneurysms after, of course, injections. We see those microaneurysms has reduced in size and in number. So we have to take this into our account. Another thing I want to add, if the patient is complicated with proliferative diabetic retinopathy, then a monthly intravitreal injection is a must, whether I put triamcinolone in the suprachoroidal space or not. Thank you.
Okay, thank you very much, Dr. Amin. Can we go to our case, Mohammed? So we have we agree with all the panelists' opinion. The right eye, there's no response, so we need to switch to other option. And the left eye, there is a response, so we continue with the same anti-VEGF. So, Mohammed, what's your what are the treatment options for chronic persistent diabetic macular edema? Do you switch to ranibizumab as you start with bevacizumab, right?
Yes, Avastin.
We start with bevacizumab, Mohammed?
Yes, I start with Avastin.
So we will switch to the ranibizumab or switch to aflibercept, or we will switch to the intravitreal corticosteroid. What you did? Sorry.
So thank you for the panelists and all my proof. Actually, I start with Avastin, as I show you, okay? And I usually, in my practice, I usually switch after 5 injections, not 3 injections, because as Dr. Magdi say and Dr. Amin say, maybe we get improvement after the 3rd or 4th injection. So usually in my life, in my practice, I usually shift after or switch after the 5 injection when we reach to the criteria of persistent or chronic persistent. Now, we discuss what are the choices that have. I start with Avastin. Should I switch to Lucentis? Should I switch to Eylea? Should I switch to intravitreal steroid? For me, I'm not. If I start with Avastin, I will not shift with Lucentis. Why? Because both of them are the same antibody, the same structure. Just one is fragmented. In our market, we usually start with the cheapest one. Actually, I think all of us will start with Avastin because Lucentis is not usually available and it's high expensive. Then, when I take a patient for 5 or 6 injections, I decide to switch for aflibercept. Aflibercept is a little bit different from the Lucentis and the Avastin because it can have an antibody for AB and placental platelet growth factor, and it's have a molecular weight in between of both of them. So this was one of my choices. The other choice that we have to give steroid. I know steroid have a very magic result, especially with the persistent or chronic persistent.
So, Mohammed, why you don't use steroids in this patient? after 6 injections and there's no response.
Yes, you are right, Mustafa, because I counsel my patient. Now we have to put for my patient, he's a phakic, and if you can monitor, he have a little bit high border IOP. So, and I discussed with him, he's a phakic and the IOP, and I told him that the possible risk that he may get cataract or increase in the IOP. He told me, do we have any other choice? I asked him, yes, we have an aflibercept. So I decided to take an aflibercept. When I go back to the literature, I see there is now a protocol conducted like protocol AC. They try to explain, it's in phase 2 clinical trials, they try to assess the early switch from Avastin to Eylea. At the same time, we have another study are conducted with my bro, Dr. Ashraf Sharawi and Dr. Ahmed Sukat, retrospective study. They assess the early switch after 3 injection of Avastin to Eylea and Lucentis, especially when we get less than 10% increase in central macular thickness. They both in both groups, they start with 3 injection of Avastin, then one group give them Eylea after not getting response, the other group getting Lucentis. Both of the group have shown improved vision after the first injection. So I decided to go for aflibercept.
Very nice, Mohammed. So for the right eye, we switch to aflibercept, and for the left eye, we continue with the bevacizumab, right?
Yes. And this is the first injection. This is the baseline when I reaching the baseline after 6 months. This is after first month from Eylea. We get a reduction in the central foveal thickness, and this
very
is
nice.
In the second month. And unfortunately, because the COVID-19, we are in complete lockdown for 4 weeks now. I stopped the injection. So I need here the opinion of Dr. Magdi. Did what I do, it's right or no? What's your opinion, Dr. Magdi?
Telling you the truth, you did the right thing. You switch it from one anti-VEGF to another, but let's not go to the commercial thing. We have both of them available, I mean, according to the availability, but as you said, there's difference between aflibercept and ranibizumab, and you said you switch it to aflibercept. You said another study was done switching from one anti-VEGF to another, like from Avastin to Lucentis, and I do start by Avastin like you. I never start by the expensive drugs. We are in a poor country, so we start by Avastin, and I don't disagree with Dr. Amin when he said after 3 injections there is no response. Yes, after 5 injections you might find a response, and this is a good point because not all the non-responder has to switch, but the patient comes to consult with you. Should I keep injecting this? And I always shift, as you said, after 5 injections, or even sometimes 6 injections, if the patient can afford earlier, I'll switch earlier. But you did the right thing. You switched from Avastin to Eylea, and you had a good response, as I see, and I think you should continue that. The question is how long you are going to continue, because again, we all know that sometimes the patient will never get dry, and I think the new slides will show us different opinion. Thank you.
Dr. Mustafa, I can give a comment.
Yeah.
Yeah, would you please go back to the image of the OCT of your case?
Okay, Muhammad, go back.
Now, when you look to the OCT, the baseline OCT, usually when I look to the OCT, I can find some predictors of the inflammatory-driven macular edema. As you know that the hyperreflective dots on the OCT, hyperreflective dots of the OCT, as many mentioned, like Professor Gabriel Koskas and Professor Eduardo Medina, he mentioned that the hyperreflective dots on the OCT are the microglial cells, and the neurosensory detachment that we found in your case, actually it's a typical finding because of the trapped microglial cells that will attract more and more inflammatory mediators. So that's why when I found such kind of edema, usually I'm thinking that this edema is more inflammatory driven. So in your case, you shift to the aflibercept. It is also a very good option. But for me, in those cases, after many injections and they're showing no response, it's better to shift them to the steroid arm because they're responding very well. You will spend the time. You will get very good rapid response to them because long-standing edema, more effect on the vision. Now, regarding the counseling of your patient, it's a very good idea. because we know that the side effect of the steroids, like the cataract and the glaucoma. Now, I one of the users of the intravitreal steroid implants in many of my cases. Actually, I didn't face the problem of the glaucoma, rather than facing the spikes of the IOP that usually we face it in the first or second month after the injection. And most of the patients, they don't need any treatment. Now, regarding the cataract, yes, is an issue, but I think the chronic persistent diabetic macular edema, it's more dangerous than the matter of the cataract that we can nowadays remove it very easily with a phaco procedure. Thank you very much.
Okay, thank you very much, Doctor. I want to know the answer of this question from our panelist. Do you think if we start with aflibercept, the result will be better? If we start with aflibercept, Mohammed and panelist, if we start with aflibercept, the result will be better from the start of the bevacizumab? Is the audience also?
Yes. How to vote? May I ask a question? How to vote? Where is the button to vote?
There's submit. You can't vote. You can't vote.
We cannot vote as a, yeah.
You are panelist.
We only can talk.
No, now you only can talk and there is no vote?
Yeah, no vote for us, yes.
But just tell me where to vote from. I mean, I don't want to vote now, but where the button to vote from?
It will appear you are panelist. You can't vote.
No, I know I can't, but where's the button?
No, there is no button for the panelist. The other participants can see the button.
Yeah.
I see. Thank you. توفيق سألتك أنا السؤال ده ما عرفتش تجاوبني ها؟
لا يا باشا أنا جاوبت يا باشا أنا جاوبت نفس الإجابة والله جاوبت نفس الإجابة.
ماشي يا حماد ماشي.
أنا عندي الأسرار كلها يا باشا ولا يهمك أنا واقف.
ماشي.
So Mohammed, you can share the result?
Yes, the result now, they say it's about 54, they say maybe. 47, they say yes, maybe have a good result.
Okay, so the opinion of our panelists, Dr. Majdi, if we start with aflibercept, if we start with aflibercept, the result will be better from the bevacizumab.
Telling you the truth, I don't think so, because we will never know who will work, which drug will work and which drug will not work. But in my opinion, giving you a little bit of clinical practice guidelines for me, once the patient is chronic, is not presented recently or early, I think we should start with aflibercept. But if the patient is coming with a cystoid macular edema with a minimal thickness 350, and he's saying that he's a recent history, I would start with Avastin. But again, a chronicity, different behavior in the disease. Long-standing disease means there is a lot of mediators in there. So we need a stronger thing to start with. This is my opinion.
Thank you very much, sir. Mohammed, would you be?
Yes.
What's your opinion? If we start with aflibercept, the result will be better?
Actually, in this subject, we have no any evidence-based data clear, but in a post-hoc analysis for protocol T, they think that in in post-hoc analysis, they go back to the data of protocol T. They start to analyze them. They think that in the group of aflibercept will get improvements, and also they will show a better VA improvement and normal anatomical functions. So that's what I found. So I go to Azortex, and also I told you I don't go for a steroid because I counsel the patient and the patient refused that. So I think I would like to ask here Dr. Amin. Dr. Amin, do you think if we added Azortex, does that make change?
Yes, of course it will make change. And I think if you started with the aflibercept from the beginning, it will make changes, because the thickness of the macula and the baseline vision is all indicative of using aflibercept. And another thing, if we use aflibercept, we don't need to wait for 5 or 6 injections. 4 injections, the patient does not respond. There is no meaning of switching back to pipazizumab or ranibizumab. So we can start with Ozurdex. So we shorten the journey for the patient.
Okay, so, just one question to Dr. Amin. What's the criteria?
Yes.
OCT on the patient. You can determine, I will start with aflibercept or with Avastin. According to the central macular thickness, according to,
if the vision is 50 and less, it's indicated for using aflibercept.
Sorry, if the vision is, it's not clear, the vision?
20/50 and less.
20/50 and less, according to the visual acuity. If the visual acuity is 20/50 or less, you start with aflibercept. Regarding the central macular thickness, is there any criteria for central macular thickness?
Yes, as post hoc analysis for protocol you showed, on a small group of people, of course, which should be interpreted carefully. If there is a 400 micron and more, the aflibercept will have a better anatomical results in comparison to bevacizumab. However, this did not show in ranibizumab unless the vision is 20/50 and less.
Okay, thank you very much. So your recommendation, if we have visual acuity, 20/50 or less, and the central macular thickness, 400 micrometer or more. So we will
no, don't need to, yes, 20/50 is the main criteria. 400 and more is lesser than it's less criteria, but it's shown in the post-hoc analysis.
Mustafa, may I ask you a question, please, Mustafa?
Yes, of course.
Do you rely in your practice in the number of central foveal thickness? Exact, as every now and then you tell us the number of central foveal thickness. For me, I don't rely on the number of the central foveal thickness.
Yes, I'm agree with you. I'm always start with the bevacizumab. Always start with Avastin.
No, I don't understand my question.
No, yes.
Okay, can I ask the panelist a question?
Okay, of course.
Okay, let's put the question in this matter. When you decide to give the patient the anti-VEGF, and when you decide to give the patient the steroids, when you look to the edema from the first time?
For me, from the first time, I didn't use this.
Yeah, because sometimes we're facing a very huge edema. Okay, as you shown in your case, with a new neurosensory detachment, and let's just say more than 500, 700 microns. So would you prefer in some cases to use like the steroids as a first line?
Okay, for me, as primary treatment, I'm always use anti-VEGF. As the primary treatment.
Good and quick answer. We have to be quick.
Yes.
We have to be quick. My recommendation also, first line is anti-VEGF. This is the gold standard for me.
Yes, if there is a refractory diabetic macular edema, if there's a non-response, we think of to switch to steroid. The primary treatment is anti-VEGF. This is my opinion, and I did that in my practice.
Me too.
Yes, but if you face the patient that is contraindicated to anti-VEGF, like the patient with recent stroke or recent MI, or the patient not afraid from taking multiple injections, and we face many patients like this in the private sector, would you prefer to use the steroid as a first line?
If there is the okay, can you answer? Okay.
Yes.
Reason, yes.
Yeah, okay.
If there is a good sin, of course.
Yeah.
But we always should start with anti-VEGF in naive and yes.
You are twisting the question. You are twisting the question.
I'm not.
We have audience. We have audience. Our gold standard in practice is primary line of treatment anti.
Yeah, sure.
Is that right or not?
Yes, of course.
Everybody's agreeing on that. But twisting,
I totally agree.
100%.
if you have contraindication, this is for sure you are pushing us to the answer. But sometimes if you have contraindication, you can wait until 4 or 6 weeks to pass and start anti-VEGF.
By the way, we forget, we have central diabetic macular edema, and patient, let's say, we cannot inject him intravitreal anti-VEGF nor steroids. We can do laser. Laser will fixate the edema till we stabilize the systemic problems and we switch back to anti-VEGF. We shouldn't
Micropulse,
forget that
Amin.
laser is treatment, is a treatment, and we shouldn't forget about it. I know it's not as first line as it was, but it's still there.
Can I ask a question, Dr. Amin?
Yes.
Direct question, direct question. Do you think a patient with a 550 micron with cystoid macular edema, non-proliferative, will be beneficial from laser photocoagulation? Yes or no?
We will get but we will get stabilized edema. We stabilize the edema
depending on what?
fix
Stabilizing
the
the edema
systemic
depending on what?
event.
Depending on what? If it's not ischemic even. If it's not ischemic, there's no ischemia in the macula, there's no ischemia in the periphery. On what basis you would do laser photocoagulation?
Yeah.
Okay, so again, because we are running behind.
I'm talking. Sorry. Okay. Okay, sorry. But just the question: if I cannot inject anything,
don't do anything. If you cannot inject, you shouldn't do
what
anything.
shall I do?
You should wait.
Control.
Yes, control diabetes.
We can stabilize.
دكتور مجدي في لي سؤال لك اخير للبانلست. هلا لو كانت هذه if we start this case from the beginning on aflibercept and the patient showing no response, what's the option? What's the option? Next option for you? Would you switch to another kind of anti-VEGF or you switch to the another arm of treatment like steroids?
Can I have the comment, please?
Yeah.
Can I comment?
Yes, please.
Yes, of course. At the beginning, you had very nice comment that including the steroid at the beginning of the treatment, it will have a better good visual acuity. To make it simple, the main problem with the diabetic macular edema is the VEGF, right?
Yeah.
So the big arm of the problem is the anti-VEGF. However, this is not the only. Always with the diabetic macular, there is some kind of inflammatory process. So if we include the steroid from the beginning with the anti-VEGF, we will have a better outcome. We will, including steroid, not necessarily intravitreal. We can do septinol. This will reduce the side effects, the glaucoma and cataract. This is number two. This is as simple as that. This is number one, sorry. Number two, we have to ask ourselves one question: why this patient is not responding or is poorly responding? Switching just anti-VEGF, it might be not solve the problem. I will guarantee if we switch into anti-VEGF, it will get a better outcome. I think if the patients have poor response, this is the time for fluorescein to rule out ischemia, and that there is ischemia, I think no sense to switch to any kind of anti-VEGF.
Okay, but if you start from the beginning on the highest end anti-VEGF, like the aflibercept, and the patient showing no response, so is there any issue to switch to another kind of anti-VEGF since the aflibercept is not achieving the goal?
You said there is no any response or poor response.
No. Let's just say there is a poor response, okay, to aflibercept. After the 3 loading doses, okay, your patient's not getting more than 5 letters and the morphology of the edema not changed. Is there any sense to change to another kind of anti-VEGF, like turning back to ranibizumab or Avastin, or you should shift to another arm of treatment like the steroid?
Before doing the reactions, let me do fluorescein, FFA.
Yeah, okay, I totally agree with you that we need to do the fluorescein and the assessing the risk factor. But let's just say that you did the fluorescein, no peripheral ischemia, everything is okay, and you assess the patient that there is no ischemic element. But my question, when you use the highest end of anti-VEGF, according to the protocol T, the aflibercept is the best one, but there is no or the poor response. Would you prefer to shift to another kind of arm, like steroids?
Shall we shift to the next question? Shall we shift to the next question, please?
Okay.
Yes, of course.
Okay.
this debate will never end because
yes.
No, because
now is the time to shift.
Last word. I mean, each case should be individualized, and
Yes.
no one from us is wrong in his management. But we think that this way is the correct one. But I think all the options can produce some kind of improvement, maybe to the highest or to the medium. But I think each case should be individualized to its.
Yes, I totally agree. Yes.
My last question now, what is the role of partial vitrectomy in refractory diabetic macular edema? Dr. Mohammed Tawfiq Hamada.
يا باشا.
حماده.
ايوه يا باشا.
حماده يلعب.
I think if you think for BBV and diabetic macular edema, you think earlier. If you think late, you will get a structural improvement with no functional improvement.
Okay. So you can hear me?
Yes.
Yes, with you, Mohammed.
Finally, when I go back searching to this, I show this diagram. He say we have to depend on many factors. We have to go for the fluorescein angiography to detect if there is a leakage, we give laser. If we have an epiretinal membrane, we go for a vitrectomy. Then we have to conclude whether the patient is a phakic, non-phakic, to add a flight percept or change to dexamethasone. As Dr. Faris say, each case will be individualized. And finally, we at least we get to define our definition for what is the meaning of persistent diabetic macular edema and what is the meaning of chronic persistent diabetic macular edema, how to deal with them, whether switching to each other, even if we debate. But this debate is actually in every conference we go, the same debate. Until now, we don't get.
Because there is no clear guidelines, Mohammed. There is no clear guidelines for switching to the other anti-VEGF.
Dr. Majdi Musa, the last word for you. What's your opinion, lastly?
My opinion, let's be honest with each other. We all try all anti-VEGF, we all try steroids, we all use whatever we have in hands to compete with diabetic macular edema. But let's go back with our guidelines, clinical guidelines. We start always with anti-VEGF, there is no doubt about it. Sometimes we can start with the cheapest because we are in a country like your country, we have to start by Avastin. I always start by Avastin up till now. But if you have the option to start by strong anti-VEGF like aflibercept, you start with it. We all know that another anti-VEGF is coming to the market in 6 months and it will stay longer. But again, anti-VEGF is the first line of treatment. And I agree completely with Dr. I think Mustafa said, or Mohammed, with the posterior subtenon, sometimes it works magically. With resistant cases, posterior subtenon was intravitreal anti-VEGF. I like that very much, and I use that very much. And I use the cheap thing, which is the triamcinolone, of course. And then we can switch to, if we start with Avastin, switch to aflibercept or ranibizumab, and I always switch. And after switching, if there is no response, at 3 injections, you have to deal with steroids. Steroids as a primary line of treatment, sometimes in pseudophakic, I'm sorry. And non-steroid responder, and I used to do drops for 1 week and I see if the patient is a responder or not. And second line also, it is a very good response to steroids once the anti-VEGF doesn't work. And we have to, as we said, tailor our treatment according to the patient. But the most important thing is controlling the systemic diabetes, controlling very important. Second thing, we have to know how the patient can afford continuing or not, because we lose a lot of patients because we cannot continue. But starting with the cheap one, shifting to the expensive one, if you can afford, and then with steroids. And I think partial vitrectomy has a role, but it's a very, very limited role, because as Dr. Mohammed said, you always think late of surgery. You always think late because you, running out of the options, and then you go to surgery. No way that you will get a visual gain. But if you start early, especially if you have a membrane, if you have contraindication, that will be a very good result. And thank you for the invitation, but this is my opinion, and I hope we have benefit for the audience, because it's nice to brainstorm with each other, but we have to have the guidelines at the end.
Thank you very much.
Thank you very much.
1 minute question?
Yes, Dr. Farid.
Okay.
Just I want to ask my colleague, anyone has an experience with vitrectomy for diabetic macular edema?
Primary vitrectomy?
Yes.
Without traction or membrane?
Yep.
What would you do? Hamada, did you do anything like this? Did you do anything like patient coming out of the blue sky with cystoid macular edema, never be injected, naive patient, and you tell him go to surgery?
No.
Have you ever done that?
No, never.
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 Because if you go to the...
However, there is a study, there is a study conducted for those
Yes,
patients.
this is a study. I think I know there is a study tell us about the primary
Yes.
vitrectomy in diabetic macular edema, but we are in a practice.
Yes, yes.
We tell
This
about
The study concluded that the primary vitrectomy is more cost effective than injection, as the cost of injections in US, the study was done in the US, it would be within 1 year more than the vitrectomy itself. So they compare it as a more cost effective. That's all what the study said.
Thank you.
Okay, thank you very much. Thank you very much to all my both and panelists. It was a very fruitful discussion, and I'm very sorry because it will take so much time. We are now 4 hours and 30 minutes sitting on the.
Yes. Thank you very much, Mohammed. Thank you, Mohammed, for your effort, for organization. Thank you for our panelists, for our Prof. Dr. Meji Moussa, for Dr. Farid Ward, for Dr. Fawaz, for Dr. Mohammed Ahmed Tawfiq, for Dr. Amin Marashi. Okay, thank you all for your nice discussion.
Dr. Mustafa, I would like to remember you. We have a third meeting.
Inshallah.
I would like to give special thanks to Dr. Wael Al-Jindi for his efforts. He have a daily conference, daily meeting with Dr. Wael. Dr. Wael, thank you very much for your support every way.
شكرا دكتور وائل. Thank you very much.
Thank you, Dr. Wael.
دكتور محمد أحمد توفيق حمادة يا باشا. شكرا. أنا بشكركم جدا ونلتقي على خير الأسبوع المقبل إن شاء الله.
شكرا جزيلا.
مع السلامة.
شكرا مع السلامة.
مع السلامة.
It was really nice. Thank you.
Thank you very much.